quick repairs. I think that we have a much clearer vision of all the structures when we do using the robotic or the camera. Bleeding and transfusion is better, ventilation outcome is better, better or the same. Bypass times are a little bit worse, but despite that, patients go home and get rehabilitated much sooner than patients that do open chest approach. And aortic dissection and stroke outcomes are a little bit worse in some samples and the same in most of them. But most actual data show that it's the same, no difference. So the same mortality, the same success rate on repairs or replacements, less bleeding, shorter hospital and ICU length of stay, cardiopulmonary bypass times slightly longer but not compromising the result, and aortic dissection and stroke, similar rates. So should be space for controversy? I don't think so. So I'm sorry if I went too fast, but I'm journalized by the flight. Thank you.
Well, thank you very much. You got us just right by on time, so much appreciated. And again, thank you for the last minute in agreeing to give this talk, and welcome.
Sure. Okay.
We're going to move on with the final talk before our group panel discussion. Next talk is going to switch towards mitral transcatheter interventions, transeptal access, solutions for the mitral annular calcification that we initially saw a picture of. Dr. Robert Smith is going to give us that talk. Thank you, Rob.
Hey, thanks for having me. Some really amazing talks, really great setup. My talk is about everything you really don't want to do in mitral valve surgery. It's about intervening on calcific mitral annular disease. This is our institution right up the road. These are my disclosures, and of note, this presentation will include an off-label use of a balloon expandable valve in the mitral valve position. So first off, mitral annular calcification, about 10% of patients and across all autopsy specimens will have it. It is way more prevalent than you would ever guess. A lot of these patients are self-selected out based on referral bias to ever get to a heart surgeon. CT and echocardiographic evidence shows MAC in about 15% of patients with cardiovascular disease. We see it all the time in Tavr patients, right? I mean, if you guys are involved in your Tavr programs, tons of these patients will show up. The incidence of MAC is about as high as 42 to 45% in patients who are elderly with cardiovascular disease, and about 25% of patients who come in with mitral valve disease will have some evidence of MAC. Now, that does not mean all MAC kind of prohibits you from operating on the mitral valve or doing a repair, but this over here on the right is pretty significant MAC, as you can see. So we know also MAC can dramatically affect the surgical risk. Risk of AV groove disruption, increased operative times, both pump and clamp times. Debridement can increase the risk of stroke. Oftentimes it can reduce the size of the valve that you can place, and there's an increased risk of paravalvular leak, both short-term and long-term. And these patients are oftentimes elderly with multiple comorbidities. The epiphany came for Tavr and MAC based on how things were going for Tavr in the aortic valve position. Tavr seats well into a calcified annulus. The balloon-mounted valves have relatively low profile, which is obviously what we need for outflow tract issues. There were case reports of Tavr in mitral valve replacements, so valve and valve with good safety profiles. And so Tavr and MAC through transeptal, transapical, and then surgical transatrial approaches were done in very highly selected patients with a kind of scattered reports with some early success. And so this then brought on the next thing, which was a global registry championed by Myra Guerrero, who is now up at Mayo. She has been a leader in this field, really providing a lot of insights to all the participants for mitral annular calcification interventions. And in this early report, they had both or 4 different types, transatrial, transapical, transeptal, and a modified transeptal, where they had a transeptal approach with a rail that went out transatrial, and you can see those down here at the bottom. And I want to see if I have access to controlling. I guess I don't. I want to control these videos. Is that possible? Yeah, I don't have control of this. Okay. Anyways, So procedural outcomes, we have technical success by MVARC in this early group of about 75%. A need for a second valve about 13%. And why was that? Because it was implanted too low or too high, and there was a resultant paravalvular leak or embolic risk. LVOT obstruction, which was almost a lethal complication in most of these patients of over 10%. Valve embolization, conversion to open surgery, LV perforation, and pulmonary vein issues. So the mortality rate was pretty high, 10% of cardiovascular mortality, but really the all-told mortality of this group was almost 30%. The concerns really come from device embolization, LVOT obstruction, difficulty in determining position for deployment, and you're going to see this slide again later, PVL, and then this high mortality rate of about 30% from those other causes, on top of which, oh yeah, we're dealing with a highly comorbid patient population who's elderly, so they don't get a lot of second chances in this group. For LVOT obstruction, one of the things that can happen is you can either have too thick of a septum or the valve gets implanted too low. One of the things they did for emergency bailouts is they started doing alcohol septal ablation. And now this has become an opportunity to pre-treat the ventricle coming into surgery in patients who have reasonable septal arterial anatomy to do a preemptive alcohol septal ablation, reevaluate the ventricle down the road to see if this is an option. Other issues is you get this really elongated leaflet, and so the really go-to now for doing this is through a transseptal approach, which is done just like a mitral clip or a valve-in-valve, where we try to get to about 3.5 to 4 centimeters above the level of the annular plane, and then place a balloon expandable valve within the mitral annular calcification for when the leaflet is too long, and we're worried about the risk of basically a SAM type of obstruction from the anterior leaflet. You can do what's called a lampoon procedure. So what you do is you get your balloon expandable valve in the ready position here, and then through a transaortic approach, you can puncture the anterior leaflet with a wire, which is then endosnared, and then you have 2 snares that come back into the atrium. And what they do is they basically create a electrocautery scalpel that will then slice the anterior leaflet. You can see that scalpel, that loop formation around the anterior leaflet that's going to pull that back, but you got to be really at the ready with your transcatheter valve. So here you can see as they complete this, the valve is in ready position. So as soon as the leaflet has been cauterized, opened up, now the valve is implanted. This valve is actually implanted a little bit deep, but the ventricle is actually quite large. The general go-to rate's about an 80-20 distribution of the valve to the mitral annular calcification. But in this case, the valve is implanted. You can see the MAC actually move out of the way, and then here you can see how the valve looks at the completion of this. That is a crazy complex procedure, okay? This is like high wire acrobatics without a net. Not recommended for early use. And this is why totally percutaneous approaches have not really tackled MAC, okay? Because it's hard. The complexity really starts at the baseline. So valves really come in all sorts of shapes and sizes. The ventricles come in all sorts of shapes and sizes and with all sorts of different dysfunction. And MAC is variable at presentation. And when MAC is involved, the patients have bigger problems. So here's the problem with the valve. If it's greater than 900 millimeters squared or less than 430 millimeters squared at the annular area, you've kind of run out of your typical valve choices, right? So you got 26 and 29. If you start getting down into the 23 range, you're just substituting mitral stenosis for mitral stenosis. So really, if you're looking at a 26 or a 29 balloon expandable valve in the mitral annular position, there's your range right there. And many, many, many patients come in outside of those ranges. The next thing is your intercommissural distance. Greater than 31 greatly increases your risk of paravalvular leak and or embolization. A lot of these patients are well outside of that range. So those are things to look for. The next thing is the ventricle of these patients are oftentimes really small. This is a disease predominantly found in elderly women with little small ventricular cavities. So oftentimes when we're doing the pre-planning CT scan, we see that the LVOT neo-LVOT projected area is oftentimes less than 150. And here's an example of one of ours right here where it is 0. The projected neo-LVOT of this patient is 0. So this is not going to work from a transseptal approach. And while there's some reasonable septum here, this patient did not have any reasonable septal perforators for trying to get her into position for doing a transseptal approach. But she's got a lot of MAC. MAC's variable on presentation. This is a wonderful paper. If you have any interest in doing transseptal valve and MAC, you gotta know this paper. This is about reducing embolization risks. This is also from Dr. Guerrero's group up in Mayo, along with Didi Wang, who's been probably the biggest CT expert in this field on this, looking at the distribution of microannular calcification and how it might be successful in implanting a valve, because really what we're using the microannular calcification for is basically a scaffold for placing the valve into, right? So what is the best scaffold that you can utilize when doing this? And so in this approach, there's a scoring algorithm. If your score is 7 or greater, you're probably very low risk for embolization. The downside is if your score is less than 7, the embolization risk is very high, and so what are you going to do then? And MAC comes in all sorts of distributions. And then the next part of the complexity is just the baseline problems of the patients. These patients oftentimes have multiple comorbidities like atrial fibrillation. They have aortic valve disease. They have tricuspid valve disease, a number of problems that make them not always the best candidate for just a transcatheter approach. They have other valve diseases that need to be addressed surgically. So getting back to this, so the concerns for balloon expandable valve and mitral calcification is going to be device embolization, LVOT obstruction from the device, from the leaflet, or from the ventricular septal thickness. Early in people's experience, they're going to have problems with where do they place the valve, which may require an emergent second valve placement. So how do we avoid that? PVL risk, and then this high mortality rate. So in the original, in the second series, which is an investigator-initiated multi-centered clinical trial called the Mitral Trial, looking at patients who had valve and MAC. Severe MS was the background, MR with some severe MS with also moderate MR. 92 patients were presented. Of those, 61 patients were turned down. So there is there's a high selection of this group, highly selected group of patients who are really candidates for the transseptal approach. So what about all those other patients? So for this, we came up with a surgically implanted transcatheter valve and native mitral calcification. And the idea here is to reduce LVOT obstruction, reduce embolization risk, and reduce PVL. And we can do this oftentimes through minimally invasive approaches so that we can improve physical recovery. So to reduce outflow tract obstruction, we remove the mid portion of the anterior leaflet at A2. Oftentimes we can remove septum via myectomy, which is, particularly through a minimally invasive approach, is easy to see once you've taken out the anterior leaflet. We can orient the valve into a standard surgical configuration, posting the posts of the valve at the trigones. And then we can implant the valve as atrially as possible to get it out of the outflow tract. We can reduce PVL by balloon sizing the valve first, make sure we actually pick the right valve size, looking for areas where there's irregularities between the prosthesis and the annulus and using felt to close those gaps, and then post-expansion of the balloon so that we can address the recoil that comes and improve the seal of the valve against the calcium. And then using a camera. I mean, that's one of the real benefits of minimally invasive surgery and endoscopy-assisted surgery is that you use a camera to look for troubled areas and then you address them. And then reducing embolization risk. We add felt to improve the surface area of implantation that improves the friction that holds the valve into place. And then we use sutures. I mean, we're surgeons, we use sutures, and we come up with simple solutions for difficult problems. So using sutures helps the valve stay into place. And then added expansion post-implantation for better locking the valve into place. So there's a couple different techniques. So we have the transatrial balloon expansion and implantation. In this we have the felt on the valve technique. This has really been championed by Isaac George, but this is from multiple centers in the US. 92% of these were S3 valves for the balloon expandable valve. 11 of these patients required an AVR, concomitant AVR. So again, addressing the complexity of the patients. 100% MVARC technical success, meaning the valve was in position and did what it was supposed to do at the end of the procedure. Gradients dropped from 10 to 4 as a result of this procedure, and they had 1 LVOT obstruction. But it's still a pretty high mortality rate, 27.5%. So while they addressed a population of patients that were not amenable to an isolated transcatheter approach, we still had a very high mortality rate. And these are very early experiences, but this really just goes to the crux of the problem, which this is a difficult patient population. This is how they do it. So first they implant, they keep the valve expanded, which is how you get it out of the jar. They take a piece of felt and they wrap it around and they suture it to the free edge of the skirt. Let's see if this plays. Oh, shoot. I would love to play that video for you, because this is going to be the balloon expansion. This is what it's going to be like. Here we go. For some reason, it is not playing. From the AV guys, is there any way I can have control of this, or do I need to get my player? Yeah, I can do it from my computer if that's easier. I feel bad, but. Oh, is it working? Okay. Now it's working in the background. Maybe better.
These are the joys of technologies, isn't it? When it's supposed to work, it never works.
You can use this mouse.
I've got this. It won't let me use
Sure.
the mouse.
It's very interesting. You've got the video in the back working.
Yeah, exactly. I can work a robot, but I can't work a PowerPoint slide. That's what's great.
I feel the same way always, Rob.
If my kids were here, this would be going great. I apologize. Here we go. Let's see. And can we switch this over now to mine? There we go. I know. Don't say anything offensive, please. Oh my goodness.
That's real artificial intelligence, man.
It gets scary. It gets scary. There we go. There we go. All right, so here they're suturing it on. Again, apologize for this. And we have now implanting the balloon. And you can see they get this as atrial possible. So what they use is the residual leaflet, and they use that and place multiple sutures in here to implant this onto the balloon once it's fully expanded. But they're able to pull the balloon back as far as possible. And what they do here by pulling the valve back, they're using the commissural tabs on the balloon expandable valve to mark the trigones so that you move them just out of the way so you rotate this lateral. And the important part here also is to remember the way that the balloon, that they get it down to a small size is they rotate it around. So when it expands, it's actually going to clockwise rotate. So you have to account that as you're opening up the balloon. But once it comes in contact with the valve, it's going to stay in place. Then you can fully expand it. But you can see a big amount of room here that's left. And then this was what it looks like in the end. So you have the valve oriented to the outflow tract. It's secured nicely into position. They've got it nice and tested. They don't see any paravalvular leak, and this is a really excellent result. Now, counter to that, and this is the way that I've typically been doing, is more the felt on the annulus technique. And so we with our colleagues at University of Virginia, which is where Gaurav was at the time, put our patients together, 51 patients, 90% of these were Sapien 3. Now, it took us through the entire evolution of where we got to, so this also included patients who had no felt at all on the annulus and just a couple sutures, but the majority of these eventually had felt through the annulus. In this series, almost 85% were size 29, 12 of them got AVRs, 21 got septal myectomies, 15 of them got a replacement or repair of the tricuspid valve, and 75% of these cases were done minimally invasively, either through a mini thoracotomy approach or through a robotic approach. Our 30-day mortality was 13.7%, with a 1-year mortality of 33%. So now we've gone from a 30% mortality at 30 days to now a 30% mortality at 1 year out. Still a very sick population, but we just learned some different pieces and parts on patient selection. It's less about the anatomy, I believe. So in this case, we have a 64-year-old gentleman who had mantle radiation for Hodgkin's lymphoma, history of CABG with an AVR, a root replacement, a pacemaker, and EF about 45% with severe calcific mitral regurgitation. This is his CT scan. It looks pretty ominous, but here we have now an intercommissural distance of 43 millimeters, which is way outside of the range of 31. And we have a valve area of 1180 millimeters squared, so that's going to be, again, way out of that range that you could do for just a typical transeptal balloon expansion. So let's see if we have, and I don't know if we have sound or not, but this is the patient as we're going through.
Baseline premises of this operation is to eliminate or markedly reduce the risk of neo-LVOT obstruction, and therefore we resect the A2 portion or the mid portion of the anterior leaflet, including all chordal elements, to make sure that this cannot be reflected back up into the outflow tract.
Clearly this has been sped up to make me look awesome.
After resection of the A2 portion of the anterior leaflet, a balloon is used to size the annulus. In addition, a balloon allows us to look for any potential risk for paravalvular leak and planning for sealing the annulus with a gasket made out of felt.
So that was a 28 Z-Med balloon.
Placing the felt, sutures are placed in a ventricular to atrial fashion, tacking the felt down and trying to go around, if possible, the calcium bar, and if not, through and to the level of the annulus at least. In this case, we use 2 pieces of felt, first to secure the posterior annulus and the trigones, and then second to overlap this with the anterior annulus coming back over the trigones to get a good seal.
So in this case, you just you get around whatever you can. You're putting this down to improve the scaffolding for the valve to deploy into, and you're taking up some of that area.
After placing the felt, the balloon is then used to reassess the annular measurements. At this point, a second assessment for possible paravalvular leak sites is also made.
And with the robot here,
We now
it's really
place
nice to use the probe
balloon expandable
graspers.
valve across the annulus and use the commissural tabs to align them to the trigones. This allows the valve to sit in an anatomic position similar to a traditional mitral valve replacement. The valve is positioned as atrial as possible with the commissural tabs positioned at the trigones, and once the felt gasket is engaged with the device, the balloon of the balloon expandable valve can be fully expanded. Once the balloon expandable valve is completely deployed, the sutures which were utilized to tack in the felt gasket then secure the balloon expandable valve into position by placing them from within the felt skirt, starting within the device, then going exterior to the device. A non-securing device is often utilized for this to increase the speed of delivery and to reduce the tension that is oftentimes placed on these sutures. The purpose of this is to reduce the risk of embolization or any device moving after coming off pump.
Yeah, so not just embolization, but if the device moves, you can increase your risk of paravalvular leak. So these sutures
After
help
placing the
reduce all
device,
of
the
that.
valve is then reassessed for its overall expansion and potential for paravalvular leak. In many instances, we will re-balloon the valve with a larger volume of the balloon to overexpand and get greater device expansion and coaptation with the underlying calcium so that it may be better seated with less recoil. In this case, we added 4 cc's to the balloon. After complete deployment of the valve was tested to assure that the leaflets are mobile. In this case, we could see a small paravalvular leak coming from around the anterolateral portion of the valve. Because of this, a small piece of felt was cut and folded to be placed into that area and then secured to the valve as well as to the annulus to plug this paravalvular.
So kind of move through this here, but we plug that paravalvular leak with that felt, and in the end, we get excellent. This is a year out now, this patient is. So he's got a transvalvular gradient of 5 millimeters of mercury and a normal outflow tract gradient of 3 millimeters of mercury. As you can see here, here's the CT scan. You can see how the valve orients nicely to the outflow tract, and there's no evidence of halt. These patients are all on Coumadin therapy. And this is the 4D CT, which we did at 6 months out to look at the evidence of that. And you can see how atrially placed this valve is in that mitral annular calcification. So as opposed to a transcatheter approach, a transeptal approach, we'd have to move that 80-20 down towards the ventricle. This is almost like a 0-20 approach here. So we can really keep it up and out. And then our neo-LVOT area was 3.45 centimeters squared. So what's really nice is even in patients who have complex disease, and I'm going to stop here because I know we got to get moving, but I just want to show you that once the anterior leaflet is out, you can actually do complex septal myectomy through here to help improve the neo-LVOT. So that patient who has a 0 on the neo-LVOT, placing the device atrial, but also doing septal myectomy through the resected anterior leaflet allows for more patients to be candidates for this. And then here we did similar to what was done with Michael's approach here. We can actually add in this now a Tavr valve that was done for her critical AS. So what we did is we have the Tavr team in the room. We'd leave the patient on pump until they're really set up and ready to go, because as soon as you take them off, now you've really exposed the LV and all the back pressure on the lungs to high pressure so that they're really ready to go. And for these, we've been using the self-expanding valves. So in general, Cytral attempts to impact the risk of LVOT, paravalvular leak, and embolization that can accompany transeptal approaches. This should be viewed as a complementary, not a competing approach with transeptal approaches. It's not better, it's just different. It continues to highlight the importance of the heart team. It requires lots of people making decisions on this, and we have a lot more to go on this one. So this is, if you're interested in getting ready for this, think your team's ready for it, please call. We'd be happy to discuss this. This is not something that you start overnight. Thank you.
Thank you very much, Rob. Very, very interesting, provocative presentation. That's great. So can we get the speakers up in the panel here so we can have discussions and questions we have? We're very good on time, so we have a good period of time before our break to have discussions.
And while the speakers are coming up, could I ask the AV guys, or Cicely, if you're back there, to put the instructions up for the texting, please? So there's a couple of ways in which you can ask questions. One will be you can use the microphones on the side, or what's this? Oh yeah. So what you would do is you would, in the address bar of your texting app, you would type the address 37607, and then you would text DeBakey. It doesn't have to be all caps, but you can put all caps in, and it will then admit you to the texting forum, and then you can text your message once you've been accepted into that forum, and your question will pop up on the screen, and the moderator can then pick from the questions and group them, or whatever you want to do, Bob. So.
Perfect. Excellent. So we have our panel up here. This is great. We had a great discussions, different looking. As they said, a lot of the speakers, there's a lot of way to do this procedures in the mitral valve. It's good to have different variety. So I'll open the forum for questions and discussions, please. So do they have to do it through the texting then? Is that how to do it?
No, you can do it like this, or you can text. But that was a great session, and thank you very much. And I must say, especially thank you to Rodrigo for being sort of a great pinch hitter. Antonio Pizzis, who was supposed to give the talk, was to travel here from Greece, and as per the regulations, had to take a COVID test before boarding, and unfortunately he was asymptomatic but COVID positive, and they wouldn't let him get on the plane. So Rodrigo, we're very grateful to you. Great talk by everybody, and you will in the lab this afternoon have an opportunity to really drill down on the details. Rob, I have a couple of questions about what you mentioned. First of all, I'd like to say a little bit about how we deal with Mac over here. I've been using the ultrasonic dissector, and there's 3 companies that make them, which our spinal surgeons use over here. The one that we've found to be most effective is made by Stryker, and it's the Sonopet. And there's a particular head, the largest head that they make for it, that we've found to be very effective. And like many surgeons over here, we deal with quite a bit of MAC, and I personally haven't done an S3 in MAC because we've always managed to debride just enough calcium on the posterior annulus to allow us to place our sutures. Obviously, you don't want to do too much because then it risks AV groove disruption. So I'd like to know what your experience is with that. And the other thing is, you mentioned that 90% of the patients got an S3 in MAC. What about the other 10%?
So go backwards. So this carried on or started really about 6 years ago now. So S3 wasn't out. So we used the XT device beforehand. And then once S3 came out, we transitioned over to that, particularly since at our institution, S3, when we first got it, were mostly 29s. The majority of these were 29 valves. And so some of the residuals were the XT device, which was a little bit shorter profile, which we used occasionally. As far as the ultrasound devices to break up calcium, I don't have much experience with them. In fact, what I usually will do is just a direct surgical debridement of the valve. So it really just depends on the extent of the calcium in the valve. When calcium gets to a little bit over a centimeter deep, or you see it penetrating all the way through on CT scan into the epicardial fat, through the outflow tract, through the AV groove, that's where we're like, this is not a surgical patient in our hands. That we would rather do a valve in MAC with a balloon expandable valve. So that's been probably the largest issue. And then the other issue has to do with the amount of patient complexity. So some of these patients, maybe we could do something there, but we have other things that need to get done, and the balloon expandable valve in MAC helps us hasten up the operation a bit, so we can get to doing some of the other things, particularly through a minimally invasive approach. So that last patient I showed where we did the valve in MAC, the septal myectomy, and did the Tavr, that was a patient who was 90 years old, who's now 92 and still attends church with their sons. So that's not a patient that for us, that I want to sit there and do a lot of valve debridement and see what we come up with. But I don't have much experience with those devices, though I definitely know people who use them and use them well.
Okay, we've got questions coming through. The first question is for Dr. Chu. Could you take a bit more about how you pre-measure your loose based on echo?
Sure, thanks, Bob. I just wanted to make a comment. I think that you do bring up a good point, Mahesh. I think that there is a cohort of patients that, depending on the center, depending on the surgeon and the surgical team, that are eligible for more aggressive surgical debridement, whether you use ultrasonic debridement, or one of our colleagues that Bob knows well has been using for years a dental drill and trying to drill parts, in the most challenging areas to be able to get a stitch through. And so I do think that because the results aren't perfect, that cohort, identifying that cohort where you can take them into the operating room and try and do a conventional valve replacement still would benefit. But it's useful to have all of these sorts of techniques as a backup in those cases when you get in there and you realize, oh my God, there's no way I can get a stitch through this. We need to look for a backup. And this is where it's useful to have that skill, expertise, that team where you can have a bailout of an S3 within felt or a ring or other things. With regards to the pre-measured loops, I'll go through this in detail, but it's really to create a systematic way to predict that length beforehand, and it takes out that guessing element when you're making a single loop, attaching it, leaving it a little bit loose, and then filling the ventricle with as much saline as you can, and then trying to eyeball, does that look okay, does that not look okay? And so this technique is meant to try and take that guessing game out of it and to make the measurements based on a pre-op TE. So every one of the patients that I take to the operating room gets a TE beforehand, make the measurements based off that TE. And again, it's an estimate. It's not perfect, as you saw, but it still was pretty good. 98% of the time that measurement was accurate. So I'll go over that in detail after in the lab for when you guys come through.
Excellent. And there's another question here. Is the hospital getting paid for the off-label use of the Tavr valves?
Yes. So it does cut into the margin, but yes.
Ever been any lawsuits from staff against hospital from radiation exposure?
This sounds like a personal question from a personal experience.
I assume that's related to doing the all these different lines in the setting of the hybrid room. Is that where that comes from?
Yeah. What I wanted to ask is the way mitral valve is being kind of these days analyzed is by a structural heart team, as has occurred for aortic valve and TAVRs. I just want to see people, the different speakers' experiences, what they have at their institution, in terms of decision making, what direction to go when they have complex mitral valves being basically referred to the institution, in terms of the opportunity of doing it less invasively, a degenerative disease versus calcification. You also have, if you've got adequate LV outflow tract, the Tendyne valve now, especially the calcified arm of the Tendyne valve. We've done lots of those. That's where I'm working. So I just want to see every speaker's kind of opinion. How do they do that? Do they have a specific structural heart team where you guys regularly discuss it with the cardiologists in terms of the assessment of these patients? Who goes for what type of operations, and we'd be interested to do that, and then we can open it to the basically audience. Go ahead, Sloan.
What I do is my structural heart interventional cardiologist and I see clinic on the same day. So we see it on Fridays. And the patients that really deserve that type of discussion are usually quite obvious. And we will see them simultaneously, and we'll discuss it between the two of us. If it looks like a non-surgical approach is the way to go, then it'll be presented at the Tavr conference as well.
But they're quite open in terms of you, if they're degenerative disease, in terms of having done surgically.
Yeah,
Because
and most of those patients will come through me. Our guys are pretty, responsible when it comes to that. They're not going to take a 45-year-old P2 prolapse and, send that to the cath lab for a MitraClip without involving me. And I think it's pretty collaborative in our institution.
Great. Rob?
Yeah, we have a robust heart team. We actually have 4 surgeons and 4 interventional cardiologists and 2 imagers that all attend mitral tricuspid clinic, which we do on Tuesdays. It's a full half day of clinic. It's particularly pertinent now as the primary trial comes out, as well as Repair MR has already been out. So these are trials looking at, in Repair MR, it's intermediate risk for degenerative valve disease for edge-to-edge therapy versus surgery, and then primary, which will be coming out, which is edge-to-edge therapy versus surgery for low and intermediate risk patients age 65 or older. It's a multinational trial, Canada, US, and Europe. And so that one will be coming up soon, about 450 patients, 1-to-1 randomization geared towards a superiority trial for surgery. So it is critical for a very robust heart team discussion on a lot of these patients and determining equipoise. And so what's really great is the relationships that you develop with your heart team, your cardiology colleagues in these kind of clinic venues really they get to see what you're able to do, what really you bring to the table, and it actually draws you into a lot of the transcatheter approaches and what they're able to do. So I'm fortunate enough, and I know Mike Chu as well does this. We're actually implanters in TEER therapy. We're implanters and transcatheter mitral valve replacement. The transeptal valve and MAX I also do with my cardiologist. So I'm just a part of that piece of the puzzle as I am the surgical piece.
Great.
Yeah, at UCSF we have a very strong collaboration environment, and we have a very strong, robust structural heart team. I mean, if some case pop up like today, we can reunite like everyone like tomorrow at most and discuss the case. But I can say that mostly, I would say like 95-98% of complex cases are discussed between all the structural heart team all the time. There's no way the patient's going to be approached without being approved by everyone. And we're doing, actually, because of this collaborative environment, we're doing a lot of hybrid procedures for mitral, and also we're doing that for hybrid coronary revascularization too. So it's working fine so far.
Great. Dr. Chu? Please go ahead.
I can't figure out the technology, and
No problem.
but I would mostly for Dr. Chu, because I do things similar to that. But my question is, with its minimally invasive approach, how do you decide when to do the magic stitch or commissural closure? Because I found like if you don't decide that before you put an annuloplasty ring, it's much harder. And I noticed you seem to rely on that. You seem not to. I'm just wondering, is there anything different in your repair techniques?
Yeah, I'd like to answer
before you
that.
make that decision?
So I'll say I've never regretted putting in a commissural magic stitch. I have regretted not putting it in. And it's usually what I think about when I have either, P1, A1, or P3, A3, prolapse. And so the closer that the problem gets to the commissure, the more likely I am to do it. And something that I learned actually from doing MitraClips was, the MitraClip doesn't work just by putting the two leaflets together and connecting them. It also works by curling them in to encourage coaptation on either side of that clip. The magic stitch does the same thing. So I do a vertical horizontal mattress that basically encourages coaptation between my first set of neocords and the commissure. And you got to be careful because you don't want to make too small an opening, so it has to be a decent sized valve. But again, I think I have had some recurrences at the commissures when I've had leaks on either side that I've been dealing with, and so I think it helps prevent that from occurring.
Just a follow-up. What about like the areas, the clefts between P2 and let's say P1?
Yeah. So you have to close, if you're doing resectional techniques, so you're doing either quadrangular or a triangular resection, those resections will often open up those clefts. Most clefts are naturally occurring. You need them in order to get the natural curvature of the posterior leaflet. So most of the time with the neocord technique, you do not need to close clefts, but sometimes clefts are pathologic, and you see that on your testing after you've corrected everything else. So it's a judgment call. I think on the case I showed you, there was a little cleft there. It could be that I could have left that cleft alone and it would be fine, but I was just a little worried about it based on the static test.
So I'd agree with Sloan. Cleft closure almost always uniformly occurs when you do a resection because you slide the tissue over towards the resection, opening up the cleft and requiring it to be closed. But it can increase your gradient slightly. With neocordia reconstruction, it's uncommon to close it, but if you wish, you can always use the most medial or lateral loop to be able to close that cleft as well. You just place the suture through both ends and pull it down at the same time to make it easy. With regards to your first question about the commissuroplasty, I use a commissuroplasty or magic stitch, I'd say less than 10% of the time. I do prefer placing it after the annuloplasty is down, and simply because the annuloplasty sutures and the annuloplasty itself will elevate the annulus, making any need for any sort of commissural adjustment relatively infrequent. In most cases, at least in my practice, most of the pathology is you know, A2, P2, you know, and I'd say that about 10% of the time I have commissural flails where I have to address it specifically with a readjustment. But in terms of a simple edge-to-edge sort of commissuroplasty, it's not, I don't use it that commonly.
Dr. Ad?
So I have a more philosophical question. So we talk about heart team and meeting and so on and so forth, and we heard 4 very good presentations. And you all actually focused on the approach. So we meet at the heart team to decide whether it's a catheter-based or surgical-based. We meet with the heart team to decide if it's a robotic versus sternotomy. But according to you, all of you, what constitutes a successful mitral valve repair? I think we have to actually start to move away from just how we do it and actually focus on what we do. For instance, how big of a ventricle is too big for cords, neocords, because remodeling can result in secondary prolapse? Or what about post-operative exercise test and an exercise-induced mitral stenosis? What type of ring should be used or collar, depending on the size of the anterior leaflet or what have you? I think those questions are very important, and I wonder, each one of you, what constitutes a successful mitral valve repair?
Yeah, I think that's a great question, and I think the answer to the question starts with being honest. There are a lot of people who are not honest when it comes to their, mitral valve repair results. And obviously, we're all very scrutinized, and we all hate a failure, recurrent MR or inadequate MR. But, even if you look at the very best surgeons in the world, published results, there's still, somewhere between a 5 and 7% failure rate, over time.
Let me stop you. Okay, that's not the. I don't think that's what I asked. So, if you have a patient 2 years after surgery with +2 MR and 0 gradient, or we have a patient 2 years out of surgery with 0 MR, but with a gradient of 15 in exercise, what constitutes success?
Well, I think both of those constitute a degree of failure. A lot depends upon how the patient's doing, but there's no doubt that putting a tiny ring on or, tethering the leaflets such that you get stenosis is not a good outcome. I mean, that is absolutely a failure. Moderate MR, not something that's, that I would consider a success, and unfortunately, most of the time, that will get worse. In my experience, if you see that, it's going to get progressively worse. Now, it doesn't mean you have to immediately reoperate on that patient, but you may have to at some point. But I think being honest and tracking your results and being honest with yourself is actually very important, because it will force you to do the very best job you can during the initial operation. And I think that so many surgeons ignore it. For instance, early in my career, I would not get an echo on the floor before the patient leaves. Now I get one on every single patient, because I want to know, I want to look my result in the eye. I want to do a check against what we saw in the operating room, okay? And I want to see that result. I want the other people on my team to see that result. And if it's not a good result, we have to look that in the eye and figure out why we didn't have that result and make it better, as opposed to what I've seen others do, which is basically just ignore it and downplay it and send the patient out.
But I think that Michael is up to something here. I know it's not new, but we actually have to use the physiology and the TE in planning on what we do, as opposed to decide what we do when we're in there, when either you fibrillate or the heart is stopped and you don't have any physiology. It's just morphology. And I think that's the next step in anything we do with technology, is to implement preoperative planning and stick to it as a roadmap.
Maybe other speakers can go ahead and answer what is, in your vision, a successful repair.
So from a pure repair, I think that the key thing that we need to focus on really is the degree of residual MR, because the degree of gradient is highly based on not only valve opening area, but also the diastology of the ventricle, which, depending on your age population, is going to greatly affect what you get. But starting with the degree of regurgitation, it's got to be less than 1+, and honestly, it's got to be not only less than 1+, you have to make sure you've addressed all the prolapse. So true repair success, from my standpoint, is you've got really kind of a zero to trace MR with addressing all prolapse segments, so nothing's coming to the level of the annular plane or above the level of the annular plane, despite the fact that you don't have any residual MR. That's true success surgically, because you don't want to have to take the morbidity of going back for that. And leaving residual prolapse will lead to a failure down the road, whether it's short-term or long-term. But as far as opening area, I think that's a bigger issue. It's like, what have you done to maximize your opening area? So can you keep it greater than 3 centimeters squared, which I think is a very important piece. Regardless of what your end issue is with the transvalvular gradient. So for instance, I have a patient who has a valve area of 3.25 centimeters squared. Looks great, but he's got a transvalvular gradient of 8 millimeters of mercury, and it's because he's got horrible diastolic dysfunction. And so I've just followed this patient. But I see all patients out to a year, and then I follow any patient who's got an abnormal echo, characteristic either 1+ or greater MR, or a transvalvular gradient greater than 5 millimeters of mercury. I follow those patients till they fall off.
Dr. Souza, your opinion?
Yeah, I would say that two very important points would be, number one, stabilize the mitral annulus. That's the reason for the annuloplasty ring. And the other thing is to make sure that you have a very adequate coaptation surface. You need to be, you need to be really focused on that, because the combination of these 2 points is going to be what is going to determine if the like a residual like 1+ or trace MR is going to evolve or not in a long-term basis. And the other thing is that, so these 2 points versus you not reduce too much the mitral annulus to make a bigger gradient. So you should keep the gradient as low as possible. I think this combination of these 3 aspects is the key for long-term success on mitral valve repair, in my opinion at least.
Not much to add. Agree with all the comments. My only thing that I would suggest is that we need to keep pushing to improve the way we repair these valves, and we need to follow that up. So, for example, to address a few of your questions, Niv, we've just recently shown that the greater the height of coaptation, the better the durability, and it's in a graded fashion, from 6 millimeters to 8 to 10 to 12, and the longer that is, the more durable it is. So I think the next step is to focus on how we assess that intraoperatively and how we improve that. The second thing is around the gradient, the transvalvular gradient. There is no doubt in my mind that it makes a difference, and we need to assess this. We just completed the camera study where we randomized patients to resection versus neocord. And my personal belief is that with neocord and a larger ring, you have better hemodynamics, especially under exercise. What did the randomized trial show? Wrong, right? So there was no difference between the 2. And that when you do exercise, then we do know that the gradients go up, but we do know that there are some techniques that are related to significantly higher gradients. For example, an edge-to-edge repair with a ring or a band. And so I think we can still make the repairs that we do better, and we need to strive for that. My last comment would be around the defining success. I agree with all the comments made here. I feel very strongly that it's the mitral repair outcomes that are the most important. However, the invasion, or I shouldn't say invasion, that's a bit too antagonistic. The growth of the edge-to-edge repair is turning us all upside down on our head. And all of us here on the panel, I'm sure, and all of you in the audience are now starting to rethink what the success really is. Because I do MitraClip, everyone else here does MitraClip. The success that's being defined for MitraClip is really challenging how we define success as surgeons. And the reality is that even if everyone in here in this room and everyone that's a surgeon across the world started only doing mitral repairs every day, all day, it will never be enough for all the patients with mitral regurgitation compared to the number of cardiologists out there. So I think we're at a conundrum in terms of really thinking carefully about how we're defining success of our mitral repairs, because the tsunami of the percutaneous edge-to-edge repair is really, bringing this question to us. and it's going to be highlighted in the primary trial moving forward.
Dr. Balke has a question.
Great talks and wonderful panel, good discussion. I wanted to push the envelope a little bit more and ask you guys what your thoughts are. We're all minimally invasive people here, and we heard 4 great talks about how to do it differently. What is your limit? Say you get a patient who has a tight LAD in addition to their degenerative mitral valve. How do you manage that patient who comes to you looking for a sternal sparing approach? And where do you stop in terms of 1 vessel, 2 vessel disease, things like that? What kind of things would you do for that patient?
Individualized. Sometimes we have coronary lesions that we feel, and when I say we, I mean the heart team. I get my interventional cardiologist involved, the primary cardiologist, and the patient. And sometimes we can treat that medically. Sometimes we can stent it ahead of time. But I always offer the patient the old-fashioned, sternotomy, cabbage, mitral. I always offer that option. We will often do it in a stage fashion where we'll do the robotic mitral first and then stent, but then we get into the debate where you've treated the mitral disease, now you have, say, single vessel, say it's a 70% LAD lesion. You now have single vessel coronary disease in a patient who's often asymptomatic, so the cardiologist will make the argument that the treatment for that is medical. So I think it gets confusing when the standard practice has always been sternotomy, bypass everything, and treat the valve.
So if we're talking about CAD that is surgically indicated approach, has a surgical indication, I would say that we can do it both at the same time. We can harvest my personal experience do that for single lesions at proximal LAD. We have a huge amount of cases doing mitral valve repair or replacement with harvesting from the right side, harvesting the REMA and putting the REMA on the LAD with a sternal sparing technique, and it goes really good. For right side,
I just had a question from that. When you put a REMA onto the LAD, do you do to the right-sided incision, same incision for the mitral valve?
Right side, everything through the right side. Yeah.
Because you have direct approach without the robot?
Without the robot. Yeah.
Okay.
For the right side targets, it's a little bit more challenging because it depends if it's more proximal or distal lesion. But definitely for CERT territory, it's impossible. So I would say that you need to do staged or like combined with PCI. I've done some cases with PCI combined with previously on the same admission and then the mitral valve repair. But I would say that for single LAD lesions, it's perfectly feasible. It's doable.
I want to say one thing about that because I feel pretty passionate about it. There's still a role for sternotomy, guys. And let me tell you, ultimately
absolutely.
grade is a live or dead patient.
Totally.
Do not end up with a dead patient by doing something overly fancy.
Sure.
And that's happened, for sure. We still need to remember that our ultimate obligation is not to sort of look good and do a cool operation that we can brag about at a meeting like this. It's to end up with a live patient and an effective result. Do not abandon that standard, no matter what.
And I know, Dr. Chu, you provide your input, and then that would be the last comment.
So I agree. So it depends on the coronary vessel, and it depends on if they're symptomatic. If it's an LAD, big juicy target, I would agree. I'd just do a sternotomy, lead an LAD, and a mitral repair. If it's a non-LAD vessel, if they have no symptoms, probably just leave it. But if they do have symptoms or questionable symptoms, Bob, when he was in London, developed a great technique to do a hybrid, simultaneously on tables. And it's just a matter of trying to manage the anticoagulation. We fortunately have a hybrid room, so it just works beautifully that way. So I think that's a great option too. I think Rodrigo's option of a Rita to LAD, I think it's great. He must have incredible hands and skill, but we haven't really
Patients probably to get exposure to that LAD from that side.
We haven't gone that route yet. And every time I think about the Rita to LAD, I think about this case that my colleague handed me, where he did a beautiful Rita to LAD and Lita to an OM, and on the 3 months after, found a type A dissection, and so I had to work around the Rita to fix the type A dissection. Anyways.
All right. Well, this was a great session. I just want to thank all the speakers for sharing their experiences and the great questions from the audience. It's getting time for the break. I'm going to pass on the microphone to our hosts, and thank you again for the participation. Thank you to our speakers.
Sorry, we couldn't get to all the questions. So we're going to have 25 minutes break. You can grab a coffee and you can visit the exhibit. One of the things that we wanted to do very well in this summit is to show as much as possible from the instrument that we need in the minimally invasive setting. So take the opportunities, visit those exhibits, and explore those instruments. It's a very good learning opportunity. Thank you so much. We'll meet again at 10:20 here for an Afib course.
Yeah, I posted on the sign up too. Everyone will come in from the back.
In the back. Okay, well, welcome back for the next session, and thank you all for spending time with the exhibitors out there. There will be some upstairs as well, and I'd just like to remind you that they provide a considerable amount of financial support that allows us to support a meeting like this, which is very expensive because of the lab component. So do please spend some time with them. I really do appreciate that. The other thing is that all the lectures that are being given over here today and tomorrow are being recorded and will appear on the DeBakey Education YouTube channel. But in addition to that, live, as they are happening, they are being live streamed on our YouTube channel, on Twitter, and various other social media platforms, Facebook. So you can inform people that you know about that, and they can log on if they're interested and listen to the talks. So we're going to move on to our Afib session, after which we'll have lunch, and Steve Hoff has very kindly agreed to moderate this for us. Steve?
Thank you, Mahesh. Welcome back, everybody. I thought it was a great session this morning on mitral surgery, and we're going to move forward with hopefully a similarly robust session today on surgery for atrial fibrillation. We'll start with our first speaker, who is Randy Wolf, to tell us about the Wolf maze.
Good morning, everybody. Time to focus again after a nice break. You know, heart surgeons are really good at pattern recognition. If you look up here, you'll see this pattern. If I show you the other side, you'll see that. But we're also good at making up patterns. So I show it to you like that, just for a second, you might think 3. And if I show you the other side like this, you might just think 6. So this can look like 1, and this can look like 4, or this can look like 3, and this can look like 6. Surgeons can't help it. They want to make a pattern even when there isn't one. So I want you to wake up for the next 20 minutes, listen to this lecture. So how many spots are here? No, there are 3. You've got to pay attention. How many on the other side? Yeah, there's 6. There's 6 on this side, and there are 3 on this side. So hopefully now everybody is awake. How many spots on the other side?
2.
No, 8. I want to share with you some things I've learned over the last many years. I was thinking about this lecture. A lot of you were in grade school when we first started this project, which is interesting and sad in a way too. The real goal of treating patients with AFib is to get them back to living their life where they don't worry about their heart every day. That's the key. And a good example is a skydiver from California. He was grounded because of AFib. He ran his own skydiving business. He couldn't fly the planes anymore. He couldn't jump out. And about 6 months after the mini maze procedure, he sent me this. Well, it played before. Now it doesn't play. When we did it before, about 30 minutes ago, it played. So, number one, he's not taking blood thinners anymore, so it's much safer for him to do what he loves to do. Number two, he can fly the planes again. And number three, under stressful conditions, which this is, he doesn't have AFib anymore. I did not promote this, he sent this to me. But sometimes we forget what the goal is. What these people really want is they don't want to have to worry about their heart every day. And the more patients in AFib the more they check their pulse all the time, they're on their cardia, and the more stress they get. And I'm going to let this play just because the end of it just freaks me out. But this is what this guy does. Crazy. I'm here at Methodist with Mahesh, the DeBakey group. These are my disclosures. I continue to work on new projects, and by the way, there's some really exciting new projects with the engineering team that you'll see in a couple years. So Afib will continue to be a focus in surgery and minimally invasive surgery, and it would behoove you to stay up with things because there are going to be some new techniques coming out. This is how it started. This is in my lab at Ohio State University. This is an acute porcine model. That's the original what became AtriCure clamp. This started with a discussion in my backyard over a beer with an electrical engineer. We took a SEM clamp, he put the electrodes on, and here I'm putting the clamp between the ribs. We've done a sternotomy on the pig, and we demonstrated with bipolar radiofrequency we could make a transmural lesion around the veins. This was with a company called Enable Medical. Enable Medical then spun off what you know now as AtriCure. But this, a lot of people have never seen this. This is from my archives, but this is the original AtriCure clamp. And this was about a year after the article came out by Hasegaer that you could find pulmonary vein triggers that could be treated endocardially, but what we were trying to do was treat them from the outside. And it worked very well, and it became what we know now as the AtriCure clamps. That's what the company was founded on. And you've probably seen them out here, you'll see them in the lab, so you know how it works. But that's how it really started. It was the whole company was based on that bipolar radiofrequency, which, by the way, is extremely safe. A lot of times patients are having a procedure that involves monopolar radiofrequency. That's why there's a possibility of injuring the esophagus. With a bipolar clamp, the energy only goes from one side of the clamp to the other, so it's extremely safe. At that time, in the very early 20s, this was what was on the scene. There were surgeons saying, if you're not doing a microwave procedure, you're not doing a good AFib procedure. There were people saying, well, if you're not doing HIFU, you're not doing a good AFib procedure, and we know what happened to that. There were people that said, well, if you're not using a laser, then you're never going to get the patient in rhythm, and we know what happened to that. So after 20 years of this, we're still left with these four options as energy to treat the AFib on the surgical side. The original slides we did are still the best. These are from the porcine model that show transmural lesions every time. So it's very effective. Initially, we didn't have FDA clearance, so I did the original cases over in University of Leiden, and they went very well, and then we started doing open concomitant cases. But I was still interested in patients who didn't need open heart surgery, but people that had lone AFib. And we first started doing lone AFib cases in 2003 at the university, and that's my mentor, Dr. Flagey, behind me, who kind of always had my back. And when you try these new procedures in your hospital, I put this slide up to remind you, it's good to have somebody who has your back, because there are experienced surgeons that can help you out and cover for you, and it's very important when you're trying something new. Don't do it by yourself. I don't recommend it. What we started with and what I still do today, two cases yesterday, one patient from Kentucky with a BMI of 40, the other patient who had a 3-vessel coronary bypass in Kansas about 10 years ago. It still pretty much looks like this. And what we achieve are complete antral isolation. You're not going to get pulmonary vein stenosis because you're up on the antrum of the left atrium. And very importantly, cardiac denervation, which is somewhat controversial, but I don't think it's really as controversial as some people think. We do some intraoperative EP testing, particularly to check the vagal nerve branches or the GPs. And very importantly, the whole time, the last 19 years, I've always closed the appendage. If you're in a place where you don't have the clip, AtriClip, use a stapler. I used the stapler on the first 1,000 cases and it worked fine. But the key is don't use a vascular stapler. Use a thick tissue load. the bronchial load on the stapler. The vascular load is 2.5 millimeters, and it closes the tissue too tightly and can tear the atrium. If you have access to the AtriClip, it's a little bit quicker, it's a little bit safer, so I do use the clip routinely now. This is the part where there's some controversy about vagal AFib. I'm a very strong believer that most people with lone AFib start with vagal AFib. And one of the beauties of the clamp and the beauty of a surgeon going from the outside in is you automatically isolate these ganglionic plexi when you do your ablation. There are a few that are outside the clamp, and we test for those, and we can do additional ablation with the pen. We wrote that paper a long time ago, and this is the innervation of the heart. Now, we talk a lot about the conduction system of the heart, but that's really anatomy. But what drives, what controls that conduction system are your autonomic nerves. These are the nerves that make your hands sweat when you're on top of a tall building and you look over the edge. These are the nerves that make your heart rate go fast when you're watching a scary movie. Why should you have a rapid heart rate? You're sitting in a chair. It's the fight or flight. It's what helped us escape lions 10,000 years ago. And now we manifest that mainly with stress. So what you'll hear from a lot of these patients is their AFib is triggered by stress. We know where these GPs are that affect this, and you can see this is on the right. This is really a mapping from EPs, and they're right around the pulmonary veins. But they aren't on the inside of the pulmonary veins. They're on the outside of the pulmonary veins. And that's one of the reasons I think the therapy going from the outside in is so effective. There is more emphasis on this. This was a recent article. Could zapping the spine help prevent AFib in high-risk CABG patients based on ganglionic plexi? Most of these nerves are mixed. They're sympathetic and parasympathetic. And I think it's real. This is a great paper. This has 167 references. Ganglionated plexi ablation for the treatment of AFib. So I still believe very strongly that one of the reasons why the AFib free rate is so high going from the outside in is because we get the GPs. On the left side, the GPs come down through the ligament of Marshall. So if you're ever doing an AFib case, divide ligament of Marshall. It will also make it easier for you to get around the left side of the veins. This was the first article. We put it out a long time ago on the mini-maze. It wasn't called the mini-maze. It was called Video-Assisted Bilateral Pulmonary Vein Isolation, Left Atrial Appendage Occlusion. About a year after I did a patient from the VA in Cincinnati, he came to me and said, you know what, you need to change the name. And I said, well, let's talk about it, George. And George said, no, I already did it. He pulled out his computer, and he's the one that named it mini-maze. I did not name it mini-maze. But it is probably better than what I was calling it, because nobody knew what we were talking about. The nice thing about what we do is that we can see everything. We can do everything. Here you can see if this will play now. There we go. It's, you can see the veins quite clearly. You can see the fat pad. That's where the ganglionic plexi lie. And you can see the majority of those GPs are taken just by putting the clamp on. We test after we release the clamp, document that we have entrance block. If the patient's in rhythm, we can also check for exit block, which I like to do. One of the patients I did on Monday had 3 ablations, and when we test the veins before we put the clamp on, only one of the 4 veins was isolated. After 3 catheter ablations, 1 vein was isolated. This, you get all the veins every time, and it makes a difference. If we go to the next little snippet here, you can see we're testing on the left, and if you hit a GP, the heart will just stop right there. Now the atrium's still fibrillating, but you get a ventricular arrest, a diastolic arrest, and that's how you know you've hit a ganglionic plexi. This is with the AtriCure pen. This is a tiny little bit of energy. You can't even feel it on your finger, but it's enough to stop the heart. It's like a carotid massage. And then as soon as you stop stimulating, you're okay again. Left atrial appendage is, as you know, very important, but there are really 4 reasons. You decrease the chance of stroke, you get patients off of blood thinners, but you also can decrease the AFib focus, something you can't do with the Watchman. The Watchman does not electrically isolate the appendage. And I can't tell you how many cases, anecdotally, where the heart's been in AFib until the end of the case, and we put the clip on, and within 2 beats, the heart's in rhythm. Now you could say that's just serendipity, but I don't think so. Sometimes the appendage is so big, you can get a reentrant circuit, a macro reentrant circuit that goes through the appendage. And as soon as you close the appendage, it's gone. Watchman won't do that. And lastly, for the last 10 years, we had to decrease the blood pressure medicines after this procedure. First, we cut them in half right away. A lot of times we get the patients off all blood pressure medicines because you're changing these receptors, these baroreceptors in the appendage, and you change the renin-aldosterone system. So you got to close the left atrial appendage. And I'm a proponent that thinks you ought to close it all the time. This appendage doesn't know its job is done, but... And closing the appendage part of the minimally invasive procedure is really the easiest part of the procedure, I think. Now this patient is not morbidly obese like the one yesterday, so this is a better video, but it's really the same. It's easy to put the clip on, it's safe, you can get it right on the base, you can see everything. We do have TEE control while we're doing this, and we're right on the base. We check the TE just to be sure, but I know it's always at the right place. You can adjust it a little bit if you like. This is a very low profile. This is the V clip. Very easy to put on. I recommend it. And there we are with the clip in place and the appendage is closed. First patient, I checked him 12 years later, and the wife said, I got my husband back. My personal experience now is over 2,500 cases. We do about 4 cases a week here, the mini maze. Hospital stay is short. The results are good. Depends on what type of AFib you have. And if you look at this article from about 5 or 6 years ago, this was a combination of over 1,000 patients with follow-up, and the conclusion was that the results were really similar to a Cox Maze 4 at 1 and 2 years with respect to number of patients in rhythm and off antiarrhythmic medications. And in my experience, it's been the same way, but this article says we need extended follow-up. Well, here's one. I got this letter last year from Godfrey Klaber from Cincinnati. He had his mini maze in 2004, so he'd been in rhythm for something like 18 years, 17 years, no medicines, no blood thinners for 18 years, and now he's 92 years old. So now I've got many patients. When we started out, we didn't do that many, but I have many patients that are out 14, 15 years, no recurrence of AFib. Doesn't matter what type of AFib they have. You can do it for people that have had multiple ablations. You'll find that the pulmonary veins, that second line, they're still transmitting, but after you put the clamp on like that, and then you test, then that second line is gone. So you can test entrance and exit block. We did a study here with 100 patients, and we looked at quality of life before the mini maze and after the mini maze, and it's very different. A lot of testimonials, a lot of people that have had 2 and 3 ablations. I've had patients that have had 5 ablations. You can still do the mini maze. So the conclusion, combination of bipolar clamp, GP denervation, closure of left atrial appendage works and is durable out to 16 years at least. Eliminating the appendage is effective. These patients don't have to take blood thinners. For a lot of them, that's just as important as being in rhythm. They just want to be off the blood thinners. We do have patients that come back, that some of these patients have been out of rhythm for 2 years, and 6 months after the mini maze, they're back in AFib. What do? We go to the cath lab. The EP that I work with here says it's 100 times easier than an EP ablation. The veins are isolated, the appendage is gone. He can focus on any area outside the mini maze. And amazingly, we're running about 100% AFib free after a follow-up catheter ablation for a mini maze where the patient's still in AFib. And lastly, as I mentioned to you, as a heart surgeon, in my experience, these have been the most grateful patients I've ever taken care of. Thank you very much.
Thank you, Randy. As this morning, we'll wait and get the panel up here after all the talks, and we'll field questions at that time. Our next speaker is Nivad, who's going to talk with us about a minimally invasive cryomaze.
Good morning. It's always hard to follow a true legend, and I'll do my best. I think that in surgical ablation of atrial fibrillation, we have a fundamental problem. And I can use different numbers and different evidence, but my understanding is going, just let's look at a company like Atrial. The thing they sell the most is AtriClip and not surgical ablation devices. So it's kind of interesting, I think, to look at it. So number one, we'll never be able to offer minimally invasive procedure as catheter-based procedure. So our only strength is going to be patients that we are taking to the operating room to do it first and foremost safely, and secondly is to offer long-term durability of what we do. Same as mitral, same as everything else. So I initially was focused only on my mini maze, but then Mahesh called me earlier this week and asked me to add a little bit, so I'm going to add some of it. I just want to let you know that I have some conflict with a company with a device that's going to be in the market very soon for atrial appendage, so I try not to talk about that as much as I can. So here is the reality in the US, based on some STS paper that we did just recently. Indeed, the vast majority of procedures for standalone atrial fibrillation in the US are being done off pump. The number one promoter for this being done is that pump is bad for the patient, for cognitive dysfunction. You hear it everywhere. And in the next few months, you'll see a paper that we actually did looking into 40 years of evidence of cognitive dysfunction and pump. And I can tell you, I am actually surprised how poor the data is and what those notions are based on, and so on and so forth. So the number one promoter is cognitive dysfunction. So 88% or so of the procedures are being done off pump, only 12% are being on pump. Is this a good thing? Maybe it is, maybe it's not. So there are two aspects here, safety, and efficacy. So what about safety? This is disturbing. I'm not talking about, someone who is expert, and you'll see actually the largest series in the world that was published on this so-called mini maze just recently, showing also disturbing results. Look at the conversion rate, which is in gray, for patients that have had so-called mini maze in the US. It started 2014 at 10.5 or so, and went down to about 5%, which is a good thing. But the percent of conversions actually went up significantly over the past few years. And what we looked at also at the STS database, but was not able to really pinpoint it to a point that we can focus and say this is why it happens, is that many centers started minimally invasive procedure off pump and actually stopped, as opposed to start and build on it in order to basically eliminate the learning curve. So what we think is happening is that we have basically a continuous learning curve, because a lot of centers are starting and stopping either due to complications or because of bad results. Now, when you have a conversion, your mortality is 5% in 2017. 5% for elective procedure that supposedly made someone to be able to dive from an airplane. We don't have 5% mortality in triple valve CABG. So if you have 6% conversion, to mid-sternotomy pump and so on and so forth, and out of these you have 5% of the patient dying, that's really not a good thing. So safety maybe is better not to put the patient on bypass, but it's better to put the patient on bypass and have the patient alive than to convert and have deaths and so on and so forth. So the STS database is actually very, very disturbing to many of us when we look at those off-pump procedures. And what about results? So results is a big issue because, we can all show letters, no offense to Randy, I know his results are really good, and I know him on a personal level for many, many years, so his results are really outstanding. But we need to actually look at results in an objective way and look at it. This is a paper we published in the European Journal, and in the gray you see minimally invasive full MACE procedure using cryo as opposed to hybrid and non-hybrid off-pump procedures. And these are results per the HRS guidelines, more or less, but you see clearly the difference at 1 year. And I'll get back to it in a second. This is to date the largest series published and it's actually a paper that's a must read, and although some of the things I'm going to show you here may come across as negative, it's not negative. You have to read also the editorial I wrote about this paper. This is over 500 patients with excellent follow-up from California by Gunn Dunnington, that we all know, a tremendous surgeon, tremendous human being, and the paper is really actually interesting. In my editorial on for this paper, I actually focused on what should be accepted as the gold standard. Is the off-pump surgical procedure is really safer than the full MACE procedure? How should success be defined and effectiveness? And what should surgeons and electrophysiologists know about the Cox-Maze procedure? Because by eliminating the most effective procedure, and I can debate with whatever wants based on my own data and others, to eliminate it from the table and say this is non-existence, there are no patients that should go for minimal full MACE procedure, we are taking away a lot of things. I always say that introducing the Converge as the standard of care for surgical ablation is like saying, mitral clip is, the way to go, and abandon the mitral valve repair because it's too complex. So these are the questions I was trying to answer in that editorial to the paper. So first, let's look at the results. Off-pump hybrid procedure. Pacemaker implantation, 1.5%, that's okay. Reoperation for bleeding, 0.8%, we may say okay. Death, 1.3%, that's not okay. That's very high. Stroke, 0.4%. Conversion, 0.4%. Phrenic nerve palsy, 1.3%. And reintubation, 0.2%. Is it really safer than a full MACE procedure done minimally invasively? And mind you, this is a very experienced center. It's not like someone who just started. And this is, whatever is being said, this is the largest series to this day that actually was published. These are results that we need to look at very, very carefully. What about success? Success is reasonable for a hybrid procedure. It's about 66% off medication at 36 months as reported by the authors. However, when you really look at it, the success is actually only 58% because 8.5% of the patient had a second ablation. So if you report the number of patients in sinus rhythm, you are not obeying by the guidelines. Whether it's important or not, it's a different question, but we need to actually focus on that because when I report my results, it's by the guidelines, meaning freedom from recurrent intervention and arrhythmia longer than 30 seconds of medications. You can't report 66% at 3 years and have 8.5% of your patient having a second ablation outside the hybrid scheme, which is surgery and catheter-based procedure. So when you read those papers, you have to actually make sure that you understand what's written. The best example is the Gilinov paper on mitral valve, single side versus biatrial, saying, you know, maybe there is no difference. Their definition of success is not according to the guidelines. Their definition of success is a made definition, saying you have to be freedom from atrial fibrillation both at 6 and 12 months, and freedom from death. That's not the HRS guideline definition. So we have in the methods to make sure that we understand what is the definition of success, because it's different and we have to actually compare. So what is my definition of treatment of atrial fibrillation? It's sinus rhythm, obviously, quality of life, symptoms, you know, palpitation, fatigue, heart failure, anxiety. And if you do it right, you have diminished stroke and increased longevity. How do I go back? So, how do we play this? Can you play it? Yeah, thank you. Oh, I have to use the mouse. So this is a minimally invasive cryomaze. You saw it multiple times. It looks like endoscopic mitral or what have you. This is what I do also for my mitrals. Oh, thank you. I put a bipolar pacing wire on the ventricle, and I fibrillate. And all the cases are being done fibrillating for mitral and for standalone mazes or combination. This is what you see from the inside. There's not too much blood, but anyhow, you see very, very well. And as you move along with this technique, you learn how to retract and you learn how to avoid blood and so on and so forth. And you can start basically the procedure according to the maze scheme. Nothing changed since Jim Cox. This is an argon-based device that I'm using in this case, but I can use the other ones, the nitric oxide from Atrial as well. And you can see how well the scope is showing you the lesion, and you basically go step by step from the inside out and complete a full lesion. This is a lesion across the roof into the appendage. This is across. Those are the two left pulmonary veins, and you cross back to the mitral valve, around the base of the mitral valve, and the appendage is above it, as you can see. This is the lesion to the mitral valve with two suctions now, one in the ventricle and one in the pulmonary vein. I want to show you this in a second. This is really important. The oblique sinus is open. And as you'll see in a second, even though we have a good lesion, the coronary sinus is not frozen. It's so thick. This is why it's so important. You see the coronary sinus down there. I don't have a pointer here, unfortunately, so I can follow it. But you can see the coronary sinus right there, completely free of freezing, even though there's a big chunk of ice inside. This is why the epicardial coronary sinus lesion is so important. You see it again, it's not frozen. You see the ice right next to it, but not frozen. So now we freeze directly over it, and so we can overlap with the lesion inside. And how can this is the pointer. So now we are doing the epicardial one from the outside to overlap, as you can see here. And often I see surgeons trying to get the back of the atrium again, but it's not important. Now you can clearly see the lesion. There are no coronaries around. And now this is something we developed in 2013 and done hundreds of these. We close the appendage with a clip through the transverse sinus with a retraction of the aorta. We published a paper on it back in the days, as we say. We can use both the original ring, original clip or the V clip. It doesn't matter. I always use a retraction suture to the appendage. It helps. Even though I've done it hundreds of times, I'm not skipping that step because it really helps. With a robot, it may be easier because you have an extra hand, but here, you know, you have only two hands, so the assistant is holding the stitch. This is the first time ever the V-clip was put through the transverse sinus. It was the first case in the world, and we did it in our place. You oversize a little bit the V-clip, so you can see the other side. You'll see it in a second. You see the other side, so you know you are beyond the appendage, and basically that's it. So let's move on because I think we can work on it in the lab. So can we skip the movie now? I just do. Okay. We publish our series in multiple different ways, but this is a minimally invasive standalone Cox-Maze procedure just for long-standing persistent and persistent patients. We don't really talk about the paroxysmals. And these are the results which I think are important. So 87% of our patients long-standing persistent AF. And as you can see at 5 years, 79% of the patients are off medication and basically in sinus rhythm according to the HRS guidelines. 73% of them never even had a cardioversion in 5 years, and 90% of them are in sinus rhythm if you allow medication. Now, it's important, and I'll show you some data from the latest number of patients we have. More than 50% of the arrhythmias we have at any time point is 30 seconds to 5 minutes. So the burden is extremely low and mostly asymptomatic. So the guidelines do ask you to report in a certain way, but now we move to a link. We offered it at least to all patients, and I'll talk to it in a second. I know I have to run. These are our results. This is our safety with, you know, an on-pump procedure, minimally invasively. As you can see, 0 conversion to stenotomy, 0 mortality, 0 renal failure, 0 stroke, 1 TIA, 2 reoperations for bleeding, 5 patients only got transfusion, 2.8%, pacemaker 2.8%, no phrenic nerve paralysis, and hospital day 4 days. So it's fairly safe compared to the other one I showed you, at least in that sense, and with results that are better and I think more sustainable. As we progressed, we have better results. This is with a new cryoprobe, which is a stiffer probe. We even have better results, but I'm not going to talk about it much. This is interesting. This is stroke over 10 years. Freedom from stroke 98.3% with 0.1 strokes per 100 patients here. Interestingly, 82% of our patients are off anticoagulation at 5 years. Only 2% of them could be off anticoagulation per our protocols, and 14% either had a relapse or there are other reasons to be on anticoagulation. This is the patient paper on the stroke, on the appendage through the transverse sinus, and this is the quality of life that we do. So lately, what we do, all patients are offered a long-term monitor link. The burden for those that are being followed more than 6 months, and this is a large number of patients, is basically 88% with 0 burden, and 0 to 0.4% have 88% with 0 burden, and 9%, I don't know what happened, 9% have 0 to 0.4% burden, and 94% of the patients are off medications. I think the link is very helpful in eliminating the need for anticoagulation. I think it's really important because it helps the cardiologists as a reassurance. So in summary, the procedure does not require special skills, very safe. It's the best single procedure success at 5 years when you report it according to the guidelines. They really follow your patients and have all those visits and so on and so forth. Very low need for anticoagulation. I believe it can be improve quality of life. And basically, we need to start to discuss all options rather than go unidimensional we'll actually, in 5 years from now, we're going to find ourselves that most of the patients are going to catheter-based procedure because most of those off-pump procedures, in many cases that are after multiple ablations, are not effective. And the future depends on patient selection. In order to happen, no gimmicks, just evidence, better devices, better follow-up. And these are my conclusions. Thank you.
Neve, thank you very much. Always data-driven and always state-of-the-art, so thank you. Our last speaker in this session is Sam Bulkey, who will tell us about a robotic approach to surgical ablation for AFib.
Thank you, Steve. Let me set up my HDMI here. Perfect. All right. First of all, I'd like to thank Mahesh. This is my 9th or 10th trip to Houston for the Re-Evolution meeting. And I'd like to thank Mahesh and Qasim, who is, and Moritz, I can't see Moritz here, but for doing a great job in putting together this meeting, and all the folks in the lab. I think who deserve a lot of thanks, because this is, as I like to say, probably one of the best, if not the best, hands-on minimally invasive meeting that you can go to, especially if you've got your open surgical cred and you want to learn how to move on and see it from a lot of the experts in the various fields. And so thank you for putting this on. My talk was supposed to be robotic maze, but I figured it would kind of be repetitive with what you heard from Neve. And as Neve said, it's hard to follow a legend. Well, it's harder to follow two legends. I'm going to talk a little bit about what I like to do, which is robotic heart surgery. And my feeling about the robot is that it's not a tool to allow you to do mitral valve surgery or a tool to allow you to do coronary surgery. It's a tool to allow you to do cardiac surgery. And once the team is facile with it and they've gone through their learning curve and they know how to use all the ins and outs of the instrumentation and the exchanges and understand how the robot works, I think it can facilitate a totally endoscopic approach to a lot of the things that we do in surgery. Probably not a heart transplant, but definitely a lot of other things. And so given that the session is on arrhythmia surgery, I figured I'd talk to you a little bit about what we do with AFib, but also what we do with other arrhythmia problems. These are my disclosures. In addition to what Randy showed, which is the fact that AFib affects people's lifestyles and does not allow them to do things like bungee jumping and hopping out of airplanes, it also kills people. And this is the Framingham study that shows the mortality for patients diagnosed with atrial fibrillation over various years, whether it's men or women. It's a stark mortality, and it ranks fairly high amongst even oncological curves. And so I think atrial fibrillation is a problem that we really, as heart surgeons, need to contribute to, especially if we can do it with very low morbidity and mortality. The fact of the matter is that catheter ablation has not been successful for the majority of patients with persistent and long-standing persistent AFib. This is a little bit old, but it's from the Bordeaux group, who invented the concept of catheter ablation in 1998. And this is a 5-year follow-up where you can see that it takes at least 2 procedures to get a 5-year success rate of 63%. So that is not at all stellar, and there's a lot of room for surgical input into this topic. And I think surgeons don't pay enough attention to lone AFib. This is the guidelines from 2017. I'm sorry, this is a paper from Jim Gammy talking about the incidence of surgery for lone AFib in the STS database. It is a little bit old as well, but only 4.6% of AFib surgery occurred in the lone setting as opposed to concomitantly with mitral valve surgery. And I don't think this number is too much better than that. If anything, it's still less than 10%. The guidelines tell us that there is a role for surgical ablation, surgical maze procedures. This is the ESC guidelines, which give minimally invasive epicardial pulmonary vein isolation a 2A with a class of evidence B. And maze surgery, obviously, we know is a 2A with class A evidence for concomitant therapy, and that's why people are doing that more and more. And here's the STS guidelines from 2017, which have been updated and talk about surgical ablation for symptomatic patients with persistent, longstanding persistent, in the absence of structural heart disease as a class 2A level B evidence. So I think there's guideline evidence for us to take on this problem and to treat it with the tools that we have at our disposal as surgeons from the outside of the heart. The Cox-Maze procedure, obviously, is the gold standard. The application of it, unfortunately, is not a gold standard, and it has not been adopted in its original form with the sternotomy and the original procedure. Thankfully, we have an ablation variant of it that allows us to do the surgery with a minimally invasive approach, whether it's on pump or off pump, as we've heard this morning. This is a paper from Neve. I think he showed you the front page of it that shows their technique in doing a biatrial cryomaze procedure, and he showed us a nice video of how to do that with a fibrillating heart. And that's pretty much what we do in our program right now, except for we use the robot. And I think the robot basically allows you to minimize the incisions, really provide a true endoscopic approach. And if you're doing mitral valve surgery with the robot, why, you can do atrial fibrillation surgery very easily. I think the robot really adds in the dexterity and the ability to put the lesions where you really need to put them with literally a 10 millimeter working port. And that's kind of similar to what Sloan showed you. I'll move along here. It does allow you both epicardial and endocardial access to the heart. The probes that we use robotically are best, the clamps I think are a little bit hard to wield if you're really doing a truly endoscopic robotic operation. The flexible cryo probes are the ones that I prefer the most, whether it's the AtriCure one or the Medtronic one. I think that, they are really, you can bring them in through a very small port and then bend them and adjust them to afford a perfect lesion. And I think you need to take your time with the lesions. If there's a little fold, you need to take that fold out. If you can't, do it over and do half of it with one side, and then the other half with the other. I think it's very important. And I'll show you some videos of our epicardial approach with the Cobra Fusion device. The original description of cryomaze done robotically was done by Randy Chitwood's group. They had in their original paper 333 patients who underwent cryomaze procedure. The lone number was 21%, 71 patients, and they had good results there. Doug Murphy also published on his experience with cryomaze procedure in his landmark paper of, I think, over 1,100 mitral cases. And I think that, again, if you're doing mitral surgery with the robot, then you can easily do atrial fibrillation surgery safely and with good results. In this series, 18% had cryomaze, and biatrial lesions was 27% of those. This is a great textbook if you're interested in robotic heart surgery, edited by Randy Chitwood, and this chapter was written by Evelio Rodriguez, in addition to Hal and Randy, and it really shows a good description of how to use this flexible cryo probe. I think most of us have started to go to 3 minutes instead of 2 minutes for each of these lesions, but basically it's the left atriotomy constitutes the the left atriotomy constitutes the line in front of the right pulmonary veins, and then the dome and the floor are done separately. And then you have to make sure that when you're in front of the left pulmonary veins that there are no folds here and that you connect to the left atrial appendage. And if there's a big space between these veins and the appendage, I will take this probe and make a line to the base of the appendage in order to get that gap. So here's the dome, the left-sided veins, and then the floor. And so that's your box lesion isolation, and this is your posterior mitral valve annular lesion. And as Dr. Ad showed us, the external lesion to the coronary sinus is extremely important, and you have to see that the two are kind of overlapping and on top of each other. My electrophysiologist, who I just talked to yesterday as I was getting on the plane to come here, told me that that is the most common site of where they find our gaps. And we can talk about this during the panel, but he did something very unique to a patient of mine that is about maybe a year out of a cryomaze of this nature, where he found the gap right there at the isthmus, at the left atrial isthmus, and instead of doing his line, the line that the electrophysiologists like to do in the left atrium, as opposed to our posterior annular line here to the mitral valve, they come from the veins on the left side and connect a little bit more to the anterior mitral annulus. And so that's their go-to. But they only have about a 40% success rate. And so what he did in this case, instead of doing that line to basically, the patient had left atrial flutter. And instead of breaking it through with that line, he went and reinforced my line in the coronary sinus and was able to get much better results. So it's kind of interesting, and it really does talk about the conversation that we need to be having with our EPs about these various issues. And then the right-sided lesions, there's been a lot of conversation about that. I don't do right-sided lesions, and I know Nibs is going to criticize me on this, on everybody, especially if they come in with a really slow heart rate, and I worry that they're going to need a permanent pacemaker at the end. But this is the lines. It's an SVC, IVC line, a line to the posterior tricuspid annulus, and then a line to the right atrial appendage, and that's the one that has been kind of accused of causing a lot of the postoperative pacemaker requirement. This is a modification of that line that was introduced by Hal Roberts and Faisal Chima to decrease the incidence of permanent pacemakers in their patients. These are the probes that are available from the AtriCure. I don't use the Medtronic one anymore, so I don't have a picture of that, but I use the one further on the left. I think it lends itself well to being positioned through a small hole, a small 12-millimeter port. And then, as I said, it bends on the inside. This was our standard procedure with the endo balloon and the ProPlege device, obviously the similar setup for our mitral valve surgeries. We've moved to a fully fibrillating heart approach if the aortic valve is competent when we're doing lone AFib surgery. This is the setup in the operating room. Again, this port here is probably bigger. This is an old picture. Now this port is exactly 10 or 12 millimeters, and if it's a very thin patient, it can be an 8-millimeter port with an extra small Alexis device, and we can show that in the lab a little bit when we go this afternoon. Let's see if I can play this video. So our landmarks, you know, it's if anybody tells you know exactly which rib space they're going through, especially in an obese patient, then they're probably lying. And so we basically try to use some of the imaging modalities that you saw Dr. Chu show in terms of how to access the mitral valve or the left atrium at the level of the hilum. But in general, it's about midway along the length of the sternal. So you draw a line along the sternum, you come out laterally midway, and that's kind of where your working port needs to be. And this is just placement. We continue to use the SI robot. If anybody notices this, that it looks a little different, it is different. We use the SI robot because I do TCABs a lot, and the XI robot does not have a stabilizer, and we'll talk more about that tomorrow. But we continue to cut down for the cannulation. It's a small little incision, and I use the femoral artery above the level of the inguinal ligament, and we have seen 0 issues with leg perfusion at that level. And I think that's a good thing to do, is to come up a little higher. And then we place our drains, and if we're doing an endo balloon case, then we place the endo balloon, but this is just to demonstrate that. And then this couple of videos here will show the lesion set. We start off now, instead of what you see here, we start off with the left atrial lesion set. So we fibrillate the heart, put a pacemaker wire behind the right ventricle, as you saw Dr. Ad's video, fibrillate the heart, cool down to 31, open up the left atrium, do our left-sided lesions, which you will see there, and then shock, and then come back and do the right-sided lesions. So this video is a little out of order. It's showing you the right-sided lesions here. First, this is a right atriotomy. This is the lesion to the tricuspid valve. And again, you have to really exclude all these folds. And if I go back and look after the lesion was made and I see a gap, I'll go back and reburn that area. Excuse me. And so each of these right atrial lesions, if it's very thin, I'll go back down to 2 minutes, but usually we'll do 3 minutes for thick tissues, and we'll definitely do 3 minutes for all of the left atrial lesions. And this is basically the same lesion set that you saw in the animation or in the pictures there. We're doing the dome, which comes across the left-sided veins, and then we'll do the floor that also connects with that dome. And in this case, I don't know if we did a specific I think we did a specific left atrial lesion to make sure that we're connected between the left atrial ostium and the left-sided veins. And then the lesion to the posterior mitral valve. And you can kind of be really fancy and draw exactly where you think it's going to be, but if you can see the CS, like Neve showed us a little bit before, and you can see the inside, then you can kind of gauge where it is. I double up on the probe and make it a hairpin loop instead of just a single line, so that there's more chance of overlapping with the inside lesion. And then as you saw in that video, there's a line that shows you the phrenic nerve. That is the bugaboo of this whole thing, where you can't let the phrenic nerve be in the way and be touched by the freezer. And then after that, we go after the left atrial appendage. We've done the transverse sinus atrial but I kind of prefer to do it this way. I think this is solid, and I've gotten good feedback that this has been pretty successful with long-term TE follow-up. This is what we use. We usually use that blue bipolar lesion, and you can see the fibrillation starting from below. You set the pacer. You basically connect this to the atrial side of your temporary pacemaker box, the Medtronic, and then you go to rapid atrial pacing, and then you set it at 800. And if you're cold enough, it'll happen like that. If you're not cold enough, it'll take a couple of tries. Sometimes we'll have to bring in one of these little alligator clips to grab on it to give you a second lead, very rarely. But that's how we do it, and you obviously have to keep the blood pressure high when you're fibrillating the heart. De-airing of a fibrillating heart is a big deal, and there are techniques of that. We put the transmitral drain all the way down to the apex. We fill the heart before defibrillating and really activate that drain very highly, and then defibrillate with the heart slightly full. And it's a big process, and everybody kind of gears up for it. The anesthesiologist is there, obviously looking at the echo and everything. This is a video from Clifton Lewis about robotic placement of a transverse sinus atrial clip. It doesn't look like it's playing, but it's pretty much what you saw with Neve's video, exactly the same. And these are, this is a small number of patients that we looked at. We have a total of 120 patients now that we've done this procedure with, which is both concomitant and lone. I think the lone population is about 40 or so. And we've seen reasonably good results with 94% freedom with antiarrhythmics and 82% without antiarrhythmics at 18 months. How about robotic off-pump ablation? I won't dwell on this too much because this catheter is quickly losing acceptance. I think one of its problems, this is the dual energy Cobra fusion device, which I've had a lot of experience with. This is a 30-patient study that we did in about a 3-month period when it first became available in 2013. And the beauty of it is that it's bipolar between the two edges of the catheter. Unfortunately, it's so successful in creating a transmural lesion that there was a lot of grunge and char that would develop inside the left atrium to the extent that people were having strokes. And if you talk to Dan Gunnington, that was the reason that this catheter is now not being used as much. And our use of it has also gone down a little bit because I think we do a better job with the fibrillating cryo procedure from the inside. But surgeons were asked to heparinize their patients because of this, and it was a big deal, even though cardiologists heparinize their patients all the time. And so this was the first we had reasonable success with this, but I think this should be done in combination with your electrophysiologist, possibly even in the hybrid room. This is a very speedy video that shows the approach from the right side, and it's the old loop device ablation that was introduced many, many moons ago. There are still surgeons that are using this device, this Cobra Fusion. I don't know if it's going to be on the market for too long, to be totally honest, but it's a very simple operation. It does not involve stiff and hard clamps, and I think you need to be really experienced at those clamps to make sure that you don't have any injuries. This is a soft, pliable device that kind of basically goes through the transverse and the oblique sinus, wraps around the 4 veins, and gives you a nice solid box lesion, which can be the basis for then a future EP ablation in the cath lab. You can see here with the robot, we get a very good view. We're taking out all the fat from the dome and from Waterston's groove, and that's where all the ganglia that Dr. Wolf was talking about, that's where they exist. And I agree with Randy that the ganglia are a major component of all of this. And so I used to do this without the robot, but once I started being robotic, then I applied it with the robot. I think it lends itself well to it, and unfortunately, as I said, the catheter got a bad rap. We started doing it from the left side so that you can manage the appendage from the same incisions. When I was doing it from the right side, I'd go back and put 3 little VATS ports in the left and then manage the appendage that way. But doing it all from the left is good, and what allows us to do it from the left is the fact that you have this stabilizer that you can lift up on the heart. That is literally the back wall of the left atrium. This here is the IVC over here. And you know, the new convergent device also lends itself to being used this way. So here we're making the opening between the IVC and the right pulmonary vein from the left-sided ports using blunt and low electrocautery dissection in order to drive this thing around the 4 veins. And I think, again, EP involvement is key. I'll just move this along really quick. We don't do this operation as much anymore, but it can be done when somebody needs concomitant coronary disease, which we do routinely this way from the left side. It does take a little bit longer, obviously, but you can drive this catheter around here. You can see it's coming in. Now this is all from the left side, so the pulmonary artery is to your right, and we're going onto the dome with the fusion device. And then you manage the appendage however way you want to manage the appendage. This is my electrophysiologist, Dr. Tung, who is fighting for position in the middle of the robot, trying to figure out how he's going to get his catheter up there, because we do this together in the hybrid room. And you can see his lasso catheter doing some mapping and then doing some zapping. You can see these are the pre-op images. The purple is active and live. And these are the post-op images after we did the posterior wall isolation, and you can see very little activity there. And then he'll zap whatever he sees. And then after we're done with the ablation, we'll go back and do this. This is, happens to be an atrial clip case. We also have used endo loops and staplers and every other technique known to man to get the appendage. Obviously, not managing the appendage is not acceptable when you're treating atrial fibrillation. We have not used the V using this technique. This is probably one of my early ones with the atrial clip, and after it was deployed, I still wanted to make sure that we were fully occlusive, so I cut the tip, and I think we were still doing some basic science research with these left atrial appendage tissues, so it was also a specimen, but then you got to suture it. Okay, so really quick, I'll go through a couple of other things that we do with the robot in terms of arrhythmia. This is an interesting problem. It's called LV summit ventricular tachycardia, and our previous chief of EP, Rod Tung, specialized in VTs, and we did the actual first in man We did a live HRS case in 2018 to ablate this lesion. And basically, it's an arrhythmia that arises at the summit of the LV, which I had never heard of before. And the summit of the LV is where the left anterior descending meets the circ. So basically, at the bifurcation of the left main. It's a very tough area for the electrophysiologist to get to. This is a patient who had multiple approaches, either aortic valve or transeptally up the left atrium, and even externally. Dr. Rod Tung came from UCLA, and they do an external dry pericardial tap, and they thread a catheter through into the pericardium, and they ablate on the surface of the heart, not knowing anything about what they're ablating, whether it's a coronary there or anything. And so this person had all of these things done, and none of it worked, and so we took him to the operating room, and you can see some of the original mapping. They place a catheter for us first, and then we decide where we're going to be, and obviously there's an angiogram that has to be done at the same time, and we basically denude this whole area of fat. And you can see here some images of that. The stabilizer, again, is extremely important. This is now a pericardiotomy behind the left phrenic nerve. You can see the appendage. This summit is right here. And this white stuff here is basically the previous catheter ablations that this patient had multiple times. And it's a very incessant ventricular arrhythmia problem. We have a duodeca catheter here to map it, and we understand exactly where the potentials are coming from. And then once, and obviously this is with the help of the electrophysiologist, they're there every step of the way. And once we decide where it's going to be, then we take out all that fat and expose the myocardium, taking care not to injure the coronary arteries because they're right there. Sometimes there's a large ramus that can get in the way. And then we bring in their ablation catheter through a small little 5mm port. So it's literally a totally endoscopic operation with a small 5mm port. And then we sit there and they basically ablate until they're happy, which can take a long time. Some of these are ones that are not easily accessible without ligating the appendage. And this is our technique for using an endo loop to ligate the appendage, which we also sometimes do in the Afib cases, but in this case it's designed to get it out of the way. And so we'll put an endo loop at the base and then cut it, empty it of all the blood, and put a couple more endo loops and kind of sausage it down. An atrial clip won't work here because you want to be able to see behind it, and an atrial clip basically obscures this area. And so that's an important distinction. But some of them are right literally at the base of where that appendage was, and then you have to ablate there. Another application is CRT, what we call smart resynchronization, and instead of them putting in a CS lead for biventricular pacing without knowledge of where that thing is going to end and without control of where it's going to end, because they're only as good as the branches of the coronary sinus in terms of putting an LV lead in. And so this is a patient who happens to be a redo, again, done through 3 little holes. You have to understand these are redos and sick patients with bad ventricles, but we're basically making 3 holes in them and then a 5mm port in the left anterior second interspace to be able to guide these catheters in. And so what we're doing here, we've opened up the posterior pericardium, avoided the vein grafts, basically taken the lung off there, and we're mapping to see which is the best site to place that left ventricular lead, or which is the best available site. And so once we decide where it is, we'll bring the lead in, and you can use a screw-in lead or you can use a sutured lead, but whatever it is, you have control over where it is. Usually we'll put 2 in there and then connect it to the pacemaker box. And then finally, I'll end with this approach here, which is also quite helpful to your electrophysiologist when they're trying to do a laser extraction, and this is what the echo shows: lots of junk in the right atrium, all up and down the lead. If they persist, you really have a risk of embolization and massive PEs. And ours is a center that was busy with lead extractions for some reason. Not as much anymore because that person left, but they used to call on us a lot to come and do this kind of thing. And it's a quick trip. If we're not in the hybrid room, the EP lab is actually in the operating room, which is another little thing that's very helpful when they call us and they need us to crash on pump on one of these extractions. They're literally in the next room and the pump is right there. And so we'll bring them into the operating room, to our room where the robot is, and we'll put a couple cannulas in the groin, go on pump, and if it's on the right side, this patient we happen to arrest them, but we can normally do it without even arresting, just on a beating heart. And you can see it's very helpful to get these things out under vision and to not injure the SVC and such. So in conclusion, I will say that robotic-assisted approaches to ablation are fairly well established. There are many programs that are doing that, mostly concomitant with mitral valve, but that doesn't mean that you can't do it for lone. And if you've got a good mitral valve program, then you can easily have a great atrial fibrillation program, a safe one with complete biatrial cryomaze lesions or maze 4 lesions. And I think that we should avail ourselves of this increasing robotic experience with mitral valve surgery. I think the robot really does enhance the visualization of this type of an operation and really can make it truly minimally invasive and truly endoscopic. And then obviously managing the left atrial appendage is right there for you, whether it's closing it with stitches or putting a clip on it from the transverse sinus. And then once you're facile with the robot, you can really use it for all the other things that your EP might want you to do. And there is really no limit to the ideas that you can come up with in terms of helping them, because the bottom line is they're on the inside, we can be on the outside, and we can be on the outside with little holes. And that's the beauty of it. Thank you very much.
Thank you, Sam. I'll invite the speakers to come up to the podium. In the interest of time, we'll probably make the discussion here a little bit abbreviated. Yeah. Good. As usual from these speakers, phenomenal experience, phenomenal images, phenomenal data. So anybody with questions for these experts? So
I'll
first
remind
question.
you again that you'll have all the time in the lab upstairs to ask as many questions as you might have.
So a couple of quick questions. The first one from the audience is the maze procedure, the importance of right-sided lesions. Neve, you want to start with that?
Yeah, I think again we have to go back to the data and how we map patients and what have you. So we just finished another mapping, ECGI mapping, which is surface mapping, but pretty accurate, and for patients with persistent or semi-persistent. It's an interesting study in general, but the one consistent aspect that we saw is that all patients have significant activity in the right side, and actually, interestingly, on the septum. And this brings, to the question is, so what constitutes an appropriate right-sided lesion? Because as you remember, the Cox procedure in the beginning, or the maze procedure, was with a septal cut in order to improve the exposure. I never quit doing the septal lesion myself, so for me the importance is there, but it's also important to take care of the crista terminalis and the interatrial septum. If you don't do it, you have some recurrences, especially in forms of right atrial flutters.
Sam, you mentioned a change in your practice. About how many patients do you use right-sided lesions on now? Any or?
Oh yeah, I would say about 60%.
Okay.
Yeah, and it's really I'm trying to avoid permanent pacemakers, and I know that what you get at the end of the surgery is not necessarily what you're going to get at the end, but it's one of those things where you have to have a little bit of a leap of faith when somebody's got a junctional escape and you're going to go and put more lesions on their right side. So yeah, about 60%.
And the flip side of that, as Neve said, is, and part of the reason that this is a bit controversial is if in the end the patient ends up after an atrial fibrillation ablation with a typical right-sided flutter, that takes the EPs about 20 minutes to do with a very high success rate. So again, this is one more of those technologies where a heart team approach is vital, I think.
I just want to comment on what Sam said. I completely disagree with you about nodal rhythm.
I knew you were going to criticize.
No, one of the problems we have is that we just look at the EKG or on the screen and say, oh, the patient is in nodal rhythm. But mind you, every time you do a right-sided lesion set, you have actually, per definition, a first-degree AV block that actually lasts for about 3 months. So often the P wave is hiding at the very end of the T, and you don't see it. So you have to establish your diagnosis by running repeated atrial EKGs. And you'll find more often than not that actually it's not nodal rhythm, it's actually sinus rhythm. You just don't see the P wave.
Yeah.
And that actually is very important. So this is one of the first things I learned from Jim Cox when I was his resident, and I never changed.
Do you guys know what he means by atrial EKGs? No, yeah, no.
I use a transeptal approach for open mazes. I don't go through directly into the left atrium. I've done that for 20 years. And using that approach, I don't do other lesions on the right atrium because I think it's too much. And started doing this, and for those of you who aren't in the United States and are more comfortable with a transeptal approach, in that approach, I do a flutter line, but I don't do any other lesions in the right atrium because you've already gone through the front of the right atrium and through the septum. And I think it's a little bit much to also add all the right lesions. It increases the chances of needing a pacemaker, but I found it very effective just to do the flutter line and use a transeptal approach.
Mike?
Yeah.
We get the floor mics on?
Sam, I think you win the biggest kahuna award, for ablating right between all the corners. I actually would struggle to be confident that there's no LAD circulating this.
Well, you see them. You dissect them out, and you basically find them and avoid them. Oh.
I actually thought, in my limited experience with robotic coronary, sometimes it's hard to see the LAD. Forget the rest of the tree. So anyways, my question is to all of you. So, when RDP colleagues go in, they map it and then they ablate it, right? So it's very much using what you know and then using it as a guide. My question to you is about why are we not exploring using better fusion imaging to help us guide what we're doing? For a lot of the hybrid work, a lot of the beat heart valvular intervention work, we've really made good headway with trying to help guide where structures are while we're doing procedures, whether it be the mitral valve, the subvalve apparatus, the aortic valve, to try and prevent sort of iatrogenic injury and things of that sort. When you have a robotic platform, it lends itself beautifully to fusion imaging.
Yeah.
And you can map it, especially when you're doing these hybrid cases together with your AP colleagues. Why not just marry the two together? And and do you see that as a helpful sort of move ablation forward towards the future?
Well, I'll speak from the VT standpoint, and maybe Neve can add because I know you've got some ideas about that fusion, mapping and putting technologies together. But we do put technologies together. So exactly what you said is correct. They ablate based on the EKGs and based on their rhythm strips that they get. We ablate based on anatomy and based on what we see. So those two are being mapped. You saw that long duodeca catheter that has 20 electrodes, and we map every piece of it to try to understand what's going on and where the abnormal rhythm is coming from. But so we add vision, which is what we bring to the table, and it has to be less invasive because nobody's going to do a sternotomy for this, to what they have in terms of electricity. Now, if we were to marry that and layer onto it, CT and things like that, then I think we're at a different level, and admittedly, we have not done that as much as we could.
There's a trial coming out from AtriCure for IST, inappropriate sinus tachycardia, and that trial includes mapping in the OR with the EP and with the surgeon.
So I think it's really an important question. So number one question we have, how valid are mappings when the patient is asleep? One of the best suppressants for arrhythmia is basically anesthesia. And we learned this with the WPW and other, those arrhythmias. So that's the number one question. Second question that I mentioned the work we have done, are we convinced that every time we map, we have the same picture? I can tell you that actually it is changing. So when you map patient A with long-standing persistent heart fibrillation today, and you mention the patient in a month, their arrhythmia is not similar. This is why an anatomical approach is probably superior to a point-by-point or chasing, the devil or whatever you want to call it. So that's absolutely, I think, a fundamental difference between us and the EPs. And this is why many EPs today are actually doing only anatomical approach. They go after isolating the pulmonary veins, and they don't, and then they come back and see what else is remained to be done. So the strength of the Cox maze is the anatomical approach. And before we go to the next question, I just want to make sure that people don't leave this room with the impression that right-sided lesion set is associated with a pacemaker. There is no evidence. There is a very good paper by Jim Cox himself that was just published a couple of years ago, and we published the largest series in the world of 800 mazes to prove that this is not true. So if we don't have time to talk about pacemakers after Afib surgery, but it's nothing with the lesion set on the right side. Absolutely nothing. You can have a sinus node dysfunction is the reason why the patient is in atrial fibrillation. And in the Gillinov paper, for instance, bilateral lesion set was associated with AV nodal delay, which is not part of the maze procedure. You don't have AV nodal delay, you don't even close to the AV node. So don't leave this room. You can be hesitant to do the right-sided lesion set, but don't explain it by saying, oh, if I do a right-sided lesion set, I have a pacemaker. That's completely not true. Absolutely lack of evidence here.
Well, I think in the interest of time, we'll go ahead and truncate the discussion. One of the advantages of this meeting is this faculty is absolutely accessible. So I would encourage the attendees as you go through these lab sessions now, engage this faculty. The number one advantage of this meeting is the relatively small, intimate nature of the lab experience that you're about to have, and so engage this faculty, ask them these questions. I think you're going to see it'll be a fabulous additional experience. So thanks to everybody for the panel, and Mahesh.
So we're going to break for lunch now. We're running a little bit behind, and I would ask you to get your lunch and come back in here, where Bob Kiai, who's the current president of ISMIX, will give us an address. And after that, Qasim will give you instructions about what you need, how you need to organize yourself up in the lab before we transition upstairs. Thank you.
Skydiving.
No problem.
I just sent a text to my senior today. He just graduated 2 years ago.
Sorry?
So welcome back, and hope everybody's enjoying this nice Middle Eastern lunch that Qasim has organized for us. I am honored and have been asked to present our speaker for the lunch session, the president of the ISMICS Society, the International Society for Minimally Invasive Coronary Surgery, Bob Kiai, who is a professor and the chief of the Department of Cardiac Surgery at UC Davis in Sacramento, a good friend and an excellent minimally invasive surgeon with a lot of precedence and a very, very healthy minimally invasive outlook on our specialty. So Bob, as it has been the tradition here in the last, I think, 3 or 4 years, Mahesh, the president of the society, the ISMIC Society, gives the luncheon speech. So without further ado, I would like to introduce Bob.
Sam, thank you very much for, I guess this is a good practice when we actually come to the annual meeting. Well, it's indeed a pleasure and honor to represent ISMICS that has partnered with the Re-Evolution Summit. Actually, I tried to dig about how long it's been going on. It's been actually since 2015. 2009, but ISMICS got involved in 2015. Yeah, 2015. But anyway, it's a pleasure to do that. We have a lot of members of our executive boards here too, including Dr. Ad and Dr. Balki, and also some past presidents. These are my disclosures, consulting with these companies. So basically, the application of innovative technology in cardiac surgery, which is what this really hum of this meeting is about. Surgeons dating back to several years ago in the 80s, 90s, starting to develop and test new devices and techniques after they have seen that there was improvement in conventional outcomes, which we've just heard from our speakers. The new technology has made surgeons dream of what can be done and ways to do it by co-opting the innovative devices and new methods. Unfortunately, there was no really society that would accept these, you can say, new modalities of doing that. So that's when ISMICS got resurrected. In 1997, and there are several the founding members of ISMICS, which is Dr. Wolf right here, was basically created to provide a venue, to provide a way by which these particular new procedures can be presented, discussed, and the techniques and the development is less invasive forms of heart surgery can be basically shared amongst individuals worldwide, and hence ISMICS was resurrected. This is a list of, since 1997, when the society was found, the presidents, and also the location where the meeting was held. As you can see, Dr. Wolf, past president, Dr. Ad, past president, and Dr. Piotr, which was the recent president, he was served for 2 years because we've skipped a year due to the pandemic. So, as you can see, we've got members from all over the world. Thus far, if I got my numbers correct, Mr. Secretary, correct me, but I think last time I checked, we've got over 1,120 members thus far, and they're represented from all these countries. So ISMICS also co-sponsors basically what we call workshops with numerous countries. We've had workshops all these places. As you can see, the pictures are Brazil, Australia. The present workshop that's coming up in 2022, November, will be in Australia. In 2023, will be in Vietnam. Our journal is Innovations, and the chief editor has had numerous, already has spoken, has raised the profile of the journal. The previous editor was Dr. Damiano, and Dr. Ad is continuing and push the journal in terms of its representation and in terms of the papers that's being published. What really ISMICS is known for, the Innovation is known for, is by these expert consensus conferences, which we've held every year. They've had a significant number of, you can say, visits when you go on the internet, and we've had some numerous excellent, and these are gone extremely well with really very well versatile, all randomized trials, This year's is going to be on atrial fibrillation, which Dr. Ad and Dr. Damiano are basically leading it. And we are trying to get also involvement of the General Thoracic Society to raise the representation by them. So these are the expert conferences, consensus that we've had. So the mission of ISMICS is to promote and expand the field of minimally invasive cardiothoracic surgery, and hence that was a great partnership that evolved way back. I remember I was talking to Volkmar Falk, was the very first president. I was approached by Dr. Ramchandani to basically kind of get this involvement. And hence, it goes along with the partnership that was created to deliver the same mission. So we've got some significant challenges in healthcare system based on most recently with the pandemic and now an ongoing significant revolution, through revolution with a potential backlog of cases all of us are confronted with. And also, of course, the world is on the edge presently with the possibility of war, basically kind of that we're all very kind of worried that will it get escalate or not. In addition, there's a significant amount of violence going on. I was on call last weekend in Sacramento, and we had the biggest first gunshot, basically 18 gunshots. I remember I was called in because a lot of them actually, it was very interesting. They all got shot to the liver and went through the diaphragm, but none of them got to the heart. So but six didn't make it. But it's extremely, I don't know, the world's become more violent. I got called again. I was doing a robotic case the other day. As soon as I finished, there was a stabbing right to the lungs, into the heart again. So it's become a violent type of thing, post-pandemic violence. So what we need to do is we need to retrench the funds, healthcare, and the research component, meetings like this, exchanging ideas. We have a significant, you can say, large middle-class population that needs to be dealt with in terms of their basic illness. And of course, the competition for patients continues to increase based on what has occurred to us. And we need to get this technology explosion unbridled so that it was not utilized due to the pandemic. So this technological innovation, whether applied or basic, whether it's applied type of science or basic science, is the insular pathway by which we can basically create new kind of, you can say, pathways in terms of the areas that we would like to develop. Surgeons that seize this challenge becomes the captains of innovation, and that's what meetings like this allows us to be able to share ideas to get there. And those who avoid these risks, basically, they are not going to be able to progress in the direction that they would like to go. So seemingly our major risk today is the cost associated with deploying this technology, specifically in the era of now we're dealing with increasing inflation. So there's definitely a need for innovations. We, as surgeons, enjoy and rely on the gold standard operations, but now patients of today are asking for basically even the cardiology, the referral physicians have realized that patients now demand improved operation, prefer no operation at all. So it's like Sloan mentioned, is the goal is to try to allow us to become as close as possible towards what the patients seek, but keeping the standards as what we want it to be. So more surgeons have begun to modify operations towards better ones, hoping to attain benefits of rapid recovery, pain reduction, improved cosmesis, neuroprotection, and operative longevity. We're under stress because, as I said, with the unexpected expenditure that occurred with COVID-19, increasing inflation due to what's going on with the war now, with the gas prices, and everything we see, the shopping, everything is just continues to increase, and that's going to also be effect on the healthcare burden, aging population. And of course, most recently, we've got significant shortage of staff for different things, delivery of care, nursing, anesthesia, surgery, perfusionists, everything. It's something that's going to be problematic. But we all need to be focused, work as a team. As you said, the heart team approach has been stated several times, and I very further emphasize that without the team approach in delivery of care of these innovative technologies, as you saw pictures of Dr. Balke with his EP cardiologist in the room, I think that those are the critical ways by which we can be able to basically have better acceptance of this innovative technology. So this is the synergy that it is with the goal to utilize the technology, deliver better care, to work as a team, delivers a state-of-the-art treatment, and improve care of patients with cardiovascular disorder. So that working as a team is extremely important, not only to basically focus on delivering the innovative care, but also utilization of less, you can say, modalities of postoperative recovery. I think the ERAS is extremely important. Being able to do a minimally invasive procedure without modifying the care these patients get postoperative, it really doesn't deliver anything. I think it's critical to work with the disciplines such as anesthesiology, with pain management, and the better ways by which these patients can recover quicker. Like prehabilitation before that is all critical to make sure that you reduce the complication, reduce the length of stay, and of course, improve patients' experience. So as an example, why teamwork is important. About a month and a half after I moved to my new location, the pandemic hit. And I was trying to create a robotic team to basically do that. So even in a pandemic situation, you can train a team, and I can tell you how we did it. So we basically have a dedicated team that we train together. The team would come on the weekend, we would sacrifice a significant amount of personal time to do these, what we call simulation platforms, to train the surgical team to improve the efficiency of robotic-assisted surgery. So we aim to basically do the investigation of how we could do that. So we did several modeling, and we were able to basically do over 20 simulation cases of mitral valve repair, valvuloplasty with new cores or resection. Annuloplasty were performed. This is the model we used with a robot in a basically thoracic cage to try to get all the members of the team trained. Duration of the critical steps were important, making sure they're documented and compared each stimulation steps. The people involved in this procedure were the cardiac surgery surgeons, residents, physician assistants, the perfusionist, anesthesiologist, cardiac OR nursing staff were all extremely important, and of course the OR equipment specialists. These are very, again, you have to get all buy-ins from all these individuals to be able to train them. And luckily, as I said, we had a dedicated team. This all occurred during the pandemic. So we came up with an operative plan, basically percutaneous training, everything, using the different technologies, teaching people how to use the knot pusher, and basically trying to utilize the technology of core knot, having to be able to do that. So if you look at the results, we put in over 88 hours of training. This is the number of hours of training, and as the team became more facile, the number of hours reduced. If you look at this page, this shows the different training periods that we did. The first training session was 3 days, second training session was 2 days, and then there's 1 day. And this is divided into in the color coding of the different procedures, different aspects of the procedure, such as docking the robot, doing a valvuloplasty, the annuloplasty, and also then closing the atrium. As you see, the hours started to decrease as the patient became more, as a team became more facile, more able to do it, and then we were able to convert that to go to the operating room. This is the first 5 cases we did, specifically the port places, that you see how the numbers is reducing. In basically yellow and green are the average. In yellow is the average for our institutions, and in green and red are basically some average, mean, and median of some benchmark basically numbers. Same thing for docking the robot, numbers reduced. As I said, the 5th case, we saw a significant drop in terms of being able to get the dock robot and put the endoscopic ports attached to it. This is the valvuloplasty, again, improvement, and again, the annuloplasty as well. So again, a team approach allows us to be able, even during a pandemic, if you do it properly, to train a team to get there. So of course you have to collect data, and you see this data allows us to be able to generate and be able to basically provide the proof that we're getting somewhere, because without data, you're just a person with an opinion. So the goal is to reduce invasiveness, reduce inflammation, reduce blood transfusions, and also eventually shorten length of stay in the hospital. So we have to be creative in our thinking, as we have witnessed in the last year around the globe. There's been some divisiveness and conflict. Medical professions should have higher standards in terms of interpersonal communication skills, systems-based practice, and professionalism. As hypocrisy implied, professionalism in our medical specialty is a commitment to the society as a whole and not self-gratification. Hence, this is not a kind of, you can say in the team, there's no me or I in the team, it's the whole team, and hence that's what basically makes you to be successful. The professionalism is all funneled as the need for compassion, integrity when dealing with patients, families, and colleagues. As Hippocrates again outlined 2,400 years ago, we need to lead the way in surgery with integrity, benefits, and respect for patients, mentors, mentees, personal and professional virtues in quest for social justice. The past year, all of us basically has made us to become more resilient, empathetic, and compassionate. We're now being confronted with the possibility of a war. We need to think about how we can do with the society and know what the society can do for you. So our annual meeting is in June. I know that a lot of individuals are reluctant based on the location of the meeting. The meeting is in Warsaw, June 15 to June 18. I would like to encourage people to really consider attending, not only because to basically promote what I just mentioned in terms of our, you can say, innovation and in terms of camaraderie to exchange ideas, but however, the most important thing is to support our Eastern European colleagues and our Ukrainian colleagues specifically, and to show solidarity. So hopefully in the next two months, things will be resolved. But as long as things do not get escalate, I very encourage people, specifically members of ISMICS, to attend the meeting in Warsaw, because I think it will be a great meeting for all of us. So in life, we all want to have a purpose and make a difference, to be useful, to be responsible, to be honorable, and to be compassionate. Above all, to matter, to count, to stand for something, and to have made a difference, as Leo Roston stated. So Confucius stated, if you're the smartest person in the room, then you're in the wrong room. So therefore, I'd really encourage the people consider changing if they have not want to adopt new technology. As Benjamin Franklin mentioned, when you've finished changing, you're finished. So it always seems impossible until it's done. So if you're not a member of ISMICS, I very encourage you to become a member, specifically if you want to drive innovation and less invasive operations. And I would like to be possible to see all of you in Warsaw in June. Thank you again for this opportunity, and it's been a great partnership.
Thank you very much. Qasim will give you some house rules and instructions on what you need to do to organize yourselves, and then we'll get moved upstairs where you can change, and we'll get going. We'd like to start at 1 o'clock, meaning the first rotation, so you've got 30 minutes to get prepared. Thank you.
I don't know if the audiovisual can put my slides again. So if you look in the back of your badge, your group color will be noted there with the schedule. So as I said this morning, we'll be having 8 groups. And since we discussed 2 topics this morning, atrial fibrillation and mitral valve surgery, what we're going to do, we're going to divide you into 2 clusters. So each cluster will have 4 groups. So the first 4 groups will be rotating in mitral valve surgeries, and the other group will be rotating in Afib. Once you are done with that topic, you will switch after a break. Each station in the lab will be 30 minutes. So if you look here, these are the clusters of the groups, and they're all color coded, and the color code is by the surgical hats, in order to help the lab staff to identify which group you belong to. And for every group, we have a lab attendant or a lab lead that will guide you through the lab and will make sure that you stick to your group and you are in the right place. If you need any help in the lab, there are 2 help desks, and they will guide you to wherever you want. You want to go to the changing room, to the restroom, they will tell you. I don't know if you can go back to this previous slide. So they will be carrying these signs. I want to go back to. Can you go back to the first slide of my slides, please? Just to give you a brief idea. Yeah. So this is how it looked. So the Afib cluster will be on that side of the lab. We'll orient you when you go there. There are 4 stations there, 4 instructors, and every group will be divided into, we'll spend 30 minutes in every station. There are some stations that the group have to split. For example, the mixed mitral today, there will be 2 stations. So instead of 6 people staying in the same station, we'll split you into 2 groups. So you might not be with, for example, Dr. Chu and another station are there. You might miss one of the station. It's not because you did not go to that station. It's just we wanted to give you the best benefit of that station. So instead of sending 6 people to that station, we'll send 3, so you can practice more hands-on. this will happen again tomorrow. So in those stations that we have A and B, the instructor will tell you to divide into 3 and 3, so you can go to that station. The last station will be mitral clip. We have one of our interventional cardiologists and his fellow that will be also teaching you some education there. So, and there will be some sponsors and exhibition inside the lab. So during the break, have the opportunity to talk to them and see what they have. They are different from what we have downstairs here. And if you have any question, you just let us know. And I hope you really enjoy this afternoon. There has been a lot of efforts by the lab there. They did a great job in getting the right instrument for every surgeon, a perfect setup. And as I mentioned this morning, we have cadavers there, so there are very strict rules about those cadavers, and there is no food or photography inside, food or drinks or photography inside the labs. So that's all, and I think we have good amount of time. We have like 20 minutes, I would say, from now to start moving up and start changing. So those who have no scrubs, there are scrubs upstairs, and there are 2 changing rooms, one for ladies and one for males, and we can change upstairs there. If you have any question, you can approach me or approach your team lead or any team member upstairs. Any other questions? That's